When they use robotic arms, if they don't want the robotic arm to break, they put a T-scan sensor in here. It's not a T shaped like a dental arch. It's like whatever the need of the shape is in here, right? They use T-scan sensors in so many industries, it's actually hard to remember them all, but aerospace, sports medicine, we were talking about it yesterday, Menish heard this yesterday, in order to study racehorse gaits and speed, they put horseshoe-shaped ones on horses, and they run them around the track, and they have a wireless device that can measure the gait and the speed and the landing elements of how the foot lands, each hoof lands, and synchronizes it all for analysis to then customize the horseshoes that the horse wears to improve that, to gain fractions of seconds on the next horse, right? They make tire tread with T-scan sensors. When you sit in your car, T-scan sensors are used to make ergonomic seat design, windshield wipers, how they adapt to the windshield. That's all T-scan sensors. Engine gasket seals, automobile industry is huge. But they put them outside airplanes to measure wind shear, right? So when someone says it doesn't work, it's too thick, you should just blow them out of the water, right? They're trying to stop you from adopting, right? You're dealing with a very sophisticated printed electronic circuit that how it works is you bite on it, walk on it, sit on it, stand on it, drive on it, and the electricity inside is displaced, and the displacement is what you see on the screen. So the more displacement is the more applied force. So those are the tall columns, and the low ones are minimal displacement. And then they're ordered in the time and sequence that they occur. And then you use that information to moderate them. Okay, so a user course is really not fluff, it's hardcore. How do you understand this? How do you get this to come out well on the screen? What's a good recording? The most important software feature is this one. Okay, it looks like it should be this one. This is of course very helpful, but this is where you understand the movie. And a user has to know how to read this without playing the movie, right? And that's a skill you develop with the T-scan. So, you know, this is a person who's struggling to bite. Just to give you some insight, the black line is your total force, and it's actually it mirrors a lot of things that the patient is able or unable to do. For example, this person is closing very slowly. They're afraid to bite down, and they're slowly squeezing to full force. And then they opened. And the second one, they did better. They kind of held their teeth together, and then they wobbled. Their mandible was like vibrating, which is what these wobbly lines are, and then they opened. And the third one, they did the best. They bit the hardest, but they still wobbled, right? And the key to getting this to come out well and to see this dysfunction, their inability to function, is to not have a lot of pink on the screen. You have to choose the right level of electricity per patient, or the sensitivity. That's called the sensitivity, and we'll go over all of this in detail. But when you have all kinds of pink, it means the sensor is too active for that person's bite strength. And then you wash out the dysfunction. If they are struggling, the sensor made it too easy for them to bite on. Or should I say the user, the operator, made it too easy for them to bite on. So you want there to be a slight struggle against the sensor, and then you can see if the person is very capable or if they have a problem. And the black line will show you their problem, right? The red line and the green line are the right half of the arch and the left half of the arch. And then we can also divide it into quadrants, and we'll do that. I'll show you what that means as well. And that has a lot to do with the disclusion time. But the general use of the T-scan is really three skills, which I'll talk about in a second. A little bit about me. I've been using the T-scan since 1984. It was built in my prosthodontic program in 1984. And so I had access to it. And no one knew what it did. No one knew how to use it. It came with a manual. It was a big, like, oscilloscope type box. And it had, from the box came a handle, you know, like this one. Certainly not as modern as this one. And some of you have had the old version, which is kind of a square rectangular handle. I think that's the one you probably have. That was the general shape. And actually that is the shape of all T-scan products, TechScan products, where the sensor connects into the handle. But dental modernized their handle because dentistry doesn't believe something evolves if the product stays the same, even though the inside of the mating and the way the sensor works is exactly the same, right? But it got modernized. But all the other TechScan products have that shape, that rectangular shape, and there can be many of them, like a mattress and bedding product where you lie on on a mattress, it'll have 10 or 12 of those sensor tabs that come off of it. This is the sensor tab. This part of the sensor is the tab, this part, and it goes into the handle. And so that's where all the electronics mate with the handle. And this is a very sophisticated electronic printed circuit. It's not too thick to use. So if someone tells you that, you should just tell them they're being ridiculous. This thing measures things they can't see with any other medium. There's no other technology you can use that can gather pressure mapping from between the teeth. Okay? So I've been using the T-scan for a long time, and so through those years I've been researching and publishing about it. I've published, it's probably now like 87 peer-reviewed articles. I am a consultant for TechScan, but I don't receive any money for sales. I don't get 6% because you buy one. I want you to buy it because it helps you, right? I want you to use it because it helps patients in ways that you can't help them without it. Because when you use ink and wax and silicone imprints and shim stock, it's all very subjective. There's no force or timing elements there. You still need those to practice, but you don't interpret them. You use the T-scan data to interpret them, and then you get much more predictable outcomes. And that's your real challenge. Why Mrs. Jones doesn't like her new teeth and Mrs. Smith doesn't complain about her new teeth. But Mrs. Smith in a few months breaks off a piece of porcelain even though she's not complaining, and Mrs. Jones, she can't get comfortable. She keeps coming back and saying it just doesn't feel right. You don't have any control over that with articulating paper, wax, shim stock, silicone. Even digital scanning, the new scanners say that you have occlusion in them. It's not occlusion. It's pictures of teeth that they put together and then they project the geometry. That's not force, right? They're just saying it's red in that mesiobuccal cusp. They don't know it's red, meaning they don't know it's high force. They're just projecting the idea, right? It's the same thing as if you put casts together, hand articulate. You can't know the forces there. Scanners just take pictures and approximate them. Nothing to do with force, pressure, or time. So if you rely on your scanning technology, you're not going to be able to help people either. You'll be able to design a nice restoration. You'll be able to mill in your office. You'll be able to do a lot of nice things that speed up the process. But all those technologies that get you to the end of a case don't get you the control over, we talked about it yesterday, the micro-occlusion. The micro-occlusion is the neurology of the teeth that you're fighting against all the time. The macro-occlusion is that the teeth mate, that they look like they touch well. But the macro-occlusion doesn't guarantee you a good micro-occlusion. And that's what you're fighting against every day, is the neurology of the patient. So that's where all the time gets wasted. That's why Mrs. Jones doesn't like her teeth. She can't feel what's wrong well, but she says it doesn't seem right. And Mrs. Smith breaks off a piece of porcelain because she bites too hard because her micro-occlusion hasn't been managed. And these are the things you're not really considering, right? No one's really talking about that. They're telling you if you line the teeth up well and you make everything work, it's going to come out okay. Think about your best orthodontic result where the patient's complaining about their bite, right? Lining up teeth doesn't guarantee outcomes. It guarantees that their setup could be ideally optimized afterwards by the T-scan, but not the setup alone. And that's the misleading part about dentistry. You go to an aesthetic lecture and they show you the finished result and they say, see how beautiful my 10 veneer case is? They don't tell you that the patient came back 15 times to complain about their bite, right? And they never show you the occlusion. And if they do, it's just a lot of ink spots. It's not real pressure mapping. It's not telling you where there's too much force, what's the right to left balance, what does the force summation show you, which side is hitting too hard, which side is too early, which side is too late, right? You don't have any of that information, right? You just have a picture of teeth hitting. And the way teeth mate doesn't guarantee that they mate well. There's a lot of information there. Some you guys are flipping through on now, and you can see there's chapters on all aspects of dentistry. And the newest version has things about the digital workflow and complex medical diagnoses. There's a bunch of things that were added from the old one. And for those of you who have the new T-scan, you really want to, if you're interested in the books, and I can give you the link to order them if you're interested, you want to buy this one. Not because it's bigger, but this is based on T-scan 8. T-scan 8 graphics are not what you own. If you upgraded your software, this is T-scan 9 and 10 graphics. That's what you'll be working with. So you want to be able to read and see a picture of the software you have, not outdated software. Although some images might be T-scan 8, like this book was updated into those books. Okay, so let's get started. So their course objectives are really to make you a better user, right? And that's something that's a challenge for everyone. No one buys the T-scan, takes it out of the box, and it works, right? You have to learn to be a user. And a user has to develop skills that you don't have. It's very much like, you know, if you learn to prep a, well, I can speak to my own experience. I'm a prosthodontist, so I went to dental school, and I had to learn to drill a MO amalgam prep in 1982. Digital occlusion is very sophisticated. There's a lot going on because it's a neurologic, it allows you to treat the neurology because it's so precise. Traditional occlusion doesn't allow you to do that. It's too biomechanical. General statements like the teeth should hit at the same time. Okay, that makes sense. Put the T-scan in there, you find out all the teeth don't hit at the same time, even though there's pink marks or red marks or blue marks on all the teeth, right? The principles make sense, but the practicality is not there, right? And that's what affects you in your office, okay? So to make you better users, you have to develop certain skills. Now, there are lots of uses that the T-scan has that you may not even be thinking about looking at. And, you know, that's up to you. But, you know, this is just general diagnosis, basically occlusal procedures that go on every day in dental practice. There are sophisticated uses, like with TMD and advanced implant concepts on how to manage where you only have a few implants in the arch versus full arch implants versus unilateral distal extension implant versus single implants between teeth. There's a lot of implant applications, but there's many applications that you can charge your patients for. Examining with the T-scan is a great way to get a baseline on their occlusal status. You know, someone comes in with 3 worn teeth on the lower left, no other teeth are worn. You know, what do we tell them? They're grinding only those 3 teeth? No, we put the T-scan in there. You'll find out their bite is like 65-35 and 40% of the force is concentrated on those 3 teeth. Now you can tell them, you know, those teeth are getting damaged by your bite. There's ways to fix that, which can be as simple as adjusting the opposing teeth, or it can be, if need be, structurally crowning the teeth, but also using the T-scan to deliver the crown so that you don't overload the crown, so that the gums recede after you give them the new crowns instead of the occlusion sanding away, right? This is one of the greatest uses, and it's just like taking x-rays, right? Patients comes in and they tell you they don't have a problem. You take an x-ray and you see they've got a huge cavity that isn't hurting them, right? You'd never find it if you didn't have some way to see it, right? So occlusion, you can see a lot with the T-scan. So, you know, this course is really not about what you do with it in your practice, it's how you use it to deal with these things, right? Okay, let me see. Oh yeah, splints, natural tooth occlusal adjustments, I guess you didn't click. But these are the things you have to learn. And in those books, chapter 4, which is really about T-scan 10 software, the second half is about all the user skills you need to learn. It's essentially what I'm going to show you in this slide, but all the details. And we're going to go through many of those details this morning. So the first one is you have to master recording. That's your primary learning skill. If you don't record well, it doesn't matter what you do, you don't have data you can use, right? And you think, well, it's recording, it's easy, the patient bites down. No, it's not easy. You have to coach the patient. You have to get them to understand what it feels like to bite into the sensor. You have to be able to watch the screen when they're recording and see what's happening and sometimes make corrections, verbal corrections. No, Mrs. Smith, bite down harder, squeeze harder, don't let go, stay there until I tell you to move left, stay there until I tell you to move right, clench harder, right? Now, why would you want to do that? Because the data they're giving you is not complete bite. It's not accurate information, but you can only tell that if you look at the screen. So typically, a lot of people put the handle in the mouth and they look at their hand, right? That's because we do that when we make impressions. We look at our hand. I'm not sure why we look at our hand. Nothing really is going to happen by looking at our hand, but we do, right? So the T-scan handle is sort of like an impression tray, but technically you need to be looking at the screen. And of course, I'll demonstrate that to you. Level 2 is mastering data software analysis and understanding what the software features are showing you so that you can apply the information you gained. And typically, a new user will just think they have to grind the pink spots. That's not true. Pink is not necessarily bad. You say, how can that be? It's so much force. What T-scan shows you is force over time. So if when someone bites down fully, when they get to the end of their bite, when they're biting their hardest, you should get some pink when you start out, right? So if the pink shows up at the end of their bite, it's pretty normal. If the pink shows up at the beginning of their bite, it's not normal, right? So you have to be able to discern that. And all through this color spectrum of force, the way the T-scan shows you the 256 levels of force it records is in a color-coded scheme. So you can have a medium force that rises too fast and other forces are lagging behind. You can have a slightly low force that rises too fast. And we'll show you what that means. And in order to understand the data, you have to be looking at the progressions that go on, not the end point. You don't actually treat anywhere near the end point. You treat between opening and closing and between beginning of excursion and end of excursion. The biting down part, the closing part, a lot of the damaging loads come from early rising high forces that aren't being absorbed well by the few teeth that are hitting at that time, right? So that's a very damaging element to those few teeth, right? Later in the scheme, if you have a lot of concentrated high force, then you have, continued overload in a certain area of the mouth. So the timing is the crucial aspect that you can't see in other things. And in disclusion timing, which none of you raised your hands about disclusion time reduction. Disclusion time is a measure of how long it takes to make an excursion and separate your back teeth. So when you bite down and slide left, for example, it can take you 1.5 seconds, it can take you 2 seconds, it can take you 0.3 of a second. In that time frame, there's muscle activity levels that are tied directly to the time frame. And so if you have long disclusion time, you have much more muscle firing. And if you have short disclusion time, you have low muscle firing. And we've seen this for years, and you'll see that today when we actually use the EMG with a patient. And it's interesting because it's a question that has been critical of the research. But so what we do in the research is we make 8 movements. Let's say we wanted to look at your disclusion time in a study. We'd make 4 movements to the right and 4 movements to the left, and we take an average. So let's say your average was 1.5 seconds. So you don't have the 8 movements. You get like a 1.2 and a 1.6 and a 1.5 and a 1.3 and a 1.7, which averages out to 1.5. You don't get 0.2 and 3.6. You don't get 0.4 and 2.8, right? It doesn't work like that. So you don't actually tell the patient how to move fast or slow. If you noticed yesterday when I was recording on Ian, I didn't tell him how fast to move. You never give the patient a speed, and they'll just naturally do it with their speed. And then you get very similar data. Sometimes I'll coach them to try to do a complete movement, and you heard me talk to him, and we'll do it today with your staff person, where slide left, keep sliding, keep going as I'm looking at the data. But I didn't tell them to do it fast, right? None of you have to tell the patient the speed. And by not telling them the speed, they move with their own speed, right? And they'll just do it with their own speed. And so that's how you get predictable outcomes. But the research, we do many recordings and we take means and standard deviations. And so that's how we know it's a very predictable data set. But it does depend on the patient's speed. And some of them can't do it well. Some of them, they kind of struggle to get over there, right? And others, they can slide out. Whenever I record on dentists, the dentists always try to beat the T-scan. So they slide fast, right? Because they're, they know they don't want to beat, that's like playing computer chess. They want to beat the computer. But you'll get to see him move by himself, basically. And that's how you get predictable data, both closing and sliding, right? And you don't really, other than coaching them to be effective at it, you never really tell them to do it fast or slow, and then it becomes very natural. And that's the beauty of the T-scan, is you actually take the data directly from the patient, and they do it very naturally once they understand what they have to do, right? So recording skills is part of that, how you get that good data. And then the data analysis, so you can make a diagnosis. And then the third part is to go to the mouth and fix it, right? And so you have to get good data at level 1 to be able to analyze and make intelligent decisions in level 2, and then you can apply level 3, right? And there's a variety of ways to apply level 3. A person who comes in and says, I can't bite down on this tooth, well, you're only concerned about recording a good set of data on that one tooth, even though you record all these other teeth, right? And you may only need to do a biting down recording because they say, I can't bite on it, right? But if they say, no, I have to be eating, it hurts, doesn't mean, I can bite on it, but when I'm eating is when it hurts me, You have to make excursive movies or clenching and grinding on the sensor. So you have to learn how to do the appropriate combination of things that gets you the information you need to make intelligent decisions about their bite. And that all starts with recording. And we'll go through recording in detail, actually. Okay? And each level builds on itself. So there's no way you can be good with the T-scan if you don't record well. And people say, well, recording seems very simple. No, it's actually very complex. It takes a lot of effort on your part to develop the skills. And I don't mean it's hard, but it's just you don't have the skills and you need to develop them. And you do that by practicing on staff. You do that by, you can even record on yourself and teach yourself like what it really feels like, and look at the screen while you're biting down on the T-scan sensor and see your own data and analyze your own data. And you know, that's a way of learning. And then doing it on patients, even if you're not going to treat them. You know, well, Mrs. Smith, I have this new technology. I want to try it out on you. You know, you've been having bite problems. Your gums are receding. I want to see what your bite looks like. You may not do any intervention, but you can capture data. And then, yeah, look at those 3 teeth. The gums have been receding for years. We've been talking to you about it. Look how much pressure's on those teeth. I didn't know that until I had this technology, right? You know, and the patients love the T-scan. They think they're like, I don't understand why other dentists don't have this. You know, they're like, you know, I went to so many dentists and you fixed this problem in 1 or 2 visits, and I've been going for months or years. You know, they don't understand why there's a lack of adoption. And the reason there's a lack of adoption is because this is really, the essence of it is the T-scan has disproved all the occlusal paradigms that came before being able to measure. You don't need to be a neuromuscular dentist and TENS anybody and open their bite 28 millimeters to treat TMD. You don't need to put people in CR. You don't need to use an appliance with every patient that has TMD symptoms. And these concepts came because of basically guessing at the paper marks and needing to rely on appliances, right? Put someone in CR with a B-splint, right? Advance their mandible with a neuromuscular orthotic and find a new jaw position. Well, the reason splints work is not because you find a new jaw position. For a small percentage of patients, they do. The people that are really overclosed and deep bites or really retrognathic, they benefit from moving their mandible. But the beauty of the T-scan is you work right in MIP. You don't have to move anybody. You don't have to find a new vertical. You don't have to open their bite. You know, if you want to do it prosthodontically because you're making a new smile or something like that, that's a different story. But treating their occlusion, you can treat right in MIP. And that's actually the first thing we're going to talk about is, you know, the type of thing that how to look at someone and see if you can treat them in MIP. We might do some of this. Let me just see what's here. Right, this is the most important part. We might do a paper mark challenge to show you that it's really difficult to choose the right contacts, which is another problem in occlusion. You know, you look at paper marks every day, and then your choice determines how well you succeed with the patient. If you choose the right ones, you get a decent outcome. If you choose the wrong ones, you get a problematic outcome. And that can start a cascade of all kinds of things that you didn't bargain for, right? And the problem is you're actually guessing at a medium that doesn't measure what you need to measure, and so you're guessing at something that doesn't actually help you choose, right? If a mark really was forceful because it was big, it would work every time, but it doesn't work every time because you can have any size mark. This is research that we've done, I've done, and others have done on carbon paper. You can have a big mark be low force. You can have a small mark be very high force. You can have a big mark be medium force. You can have a small mark be medium force. You can have a small mark be low force. You can have a big mark be high force, right? So how are you going to know? There's no way to know. And the challenge then is when you choose these marks because someone said, you know, use the big marks for high force or the bullseye's high force, none of it is true. Science has shown it's no relationship between paper mark size and load. So then when you choose these marks, you may succeed. So what does succeeding mean? Well, the patient can accept it. That's one level of success. But many patients don't actually know. The truth is they don't really know if it's good. If it feels okay, it means they can tolerate the arrangement. But they could tolerate a 65 left, 35 right arrangement. One person could tolerate that. Some of you may have one of those in your mouth and not even know it because your neurology is not responding. But someone else may not tolerate, you know, a 3 or 4% imbalance. They may not be able to take that. And so when you don't know who that is when you start. You don't have any idea who that is. So the T-scan allows you to get very high tolerances per patient. Okay, so we may get to that, but it's more important that you learn about recording. Turbo versus non-turbo recording. This is crucial. Turbo recording is 0.003 of a second. Non-turbo is 1/100th of a second. T-Scan 1, which I worked with in 1984, only recorded in non-turbo. That was the first T-Scan. It was still great. It recorded in 1/100th of a second. But 0.003 of a second allows you to see a lot more detail. And so I'll show you how to turn on your turbo, and I'll also show you what that means in terms of the data, with an example of the same person doing the same thing. One is a turbo recording, one's a non-turbo recording. Recording sensitivity. This is another crucial aspect of learning to use your T-Scan. You don't want to have a lot of pink on the screen. If you get a lot of pink, you don't have a discerning sensor, a discriminating sensor. You want the sensor to be resisting the patient just a little bit, and then you get to see their capability. With too much pink, you wash out all their dysfunction, you make the sensor too active, you also get a lot of false data. So if you're ever at a lecture and someone says, yeah, I use the T-Scan, and then they show an image and there's pink everywhere, they have no clue what they're doing with it, okay? No clue whatsoever. They're just giving it lip service, okay? And that's important, because people come up to me and they say, how did that guy show that T-Scan data? He has no idea what he's doing, right? A user with knowledge can tell, right? A user without knowledge would say, oh, that looks cool. I wonder if that's helpful, right? The person who shows all the pink doesn't ever show them how they use it. They just sort of give it lip service to say that, like, I have another digital tool, okay? Yes?
When you want to set the sensitivity, what's the ideal? Do one pink peak, 2, 3?
1 to 2 pinks
1 to 2 is
at full force, so at 100%. And I'm going to go through that, what's ideal. But again, you don't have to throw the data out if you have 4 pinks or 3 pinks. You can use it. But once you get up 5, 6, 7, 8, 9, 10 pinks, you're going to have a lot of false data. See, the sensor becomes more active. If you can generate a lot of pink, the surface of the sensor responds easier to the teeth coming into contact, and it becomes like too thick articulating paper. It's active before you actually reach contact, you know, or you reach tooth approximation, because, like I said, the T-Scan doesn't measure contact. So you want the sensor to not respond until it's compressed into itself and actually gathering real data. If it responds because you approximate the surface, now you're getting false data, right? So like I said, that's like 200 micron articulating paper. It gives you lots of ink spots, but not only a handful of them are real. Most of them are artifact, right? And so you need to mute the sensor in order to make a good recording. And it's not hard to do, but this is one of the most critical aspects.
So do you start off low then?
As low as you try to keep it low, right, on the left side of the scale, and you get the patient to bite into the sensor, and you look at what they're capable of. And if you make them squeeze hard and they don't give you any pink, you turn it up a little. If they squeeze hard and there's 7 pinks, you turn it down, right? Yesterday's patient in the dental tubules lecture, we were at this meeting in Brighton Beach, we had to use the lowest level for this dentist. And that's not atypical for men. But a TMD patient who's weak, right, you got to turn it up, right? But you also want to turn it up only as little as possible to where they struggle to give you data, but they're still struggling, and then you can see the dysfunction. You don't want to wash out the dysfunction. And you'll see what I mean certainly when we record on Manish's staff person. This is very important. Understanding the force versus time graph and the total force line, that's the black line, and what it's showing you, and how to read it without playing the movie, so that you can tell the movie is useful, you can tell whether the data was well gathered, you can tell if the patient has issues, right? And this is probably one of the most important things as a user you have to be able to do, and how to divide it into quadrants, which is not hard, but what that really means, and how to read the graph when it's in quadrants. That has to do with excursive movements. Let's see, recording technique, yeah, that's the same thing. This is it. In other words, the graph, the recording characteristics and the type of graph illustrates a lot about the patient. So those are the things that we're going to talk about with respect to recording. And then we'll have this volunteer recording session. And I wanted you guys to try to record on each other, but very few people brought T-scans, so you probably won't be able to do that. Although you can, if you want to try to record on each other, you can use my computer, or Ash, I don't know if you have a T-scan with you.
For my T-scan, but Well, I've got an Apple Mac, so I'm not set up on my computer yet.
Yeah. So if you have a Mac, you can't, yeah. But so,
I've
you
got
know,
support and everything.
that's cool. So, you know, if you want to try, like at the break, to record on each other, you can use my computer. You know, that's a helpful thing. Or I can help you record. But, okay, first thing. T-scan allows you to treat an MIP, where you do most of all your dentistry, without appliances. You don't need appliances. Okay, you might want to make appliances. You might say to yourself, gee, my practice, I make all these appliances, I make a lot of money. What if I stop making appliances? How am I going to make money? Well, you can charge for treating people in MIP. You know, you can charge a lot of money, actually. Disclusion time reduction is a very lucrative procedure. It costs in the United States about $5,000, and it takes 3 or 4 visits. And there's no cost. There's no lab cost. There's no splint cost. There's no, right? It's not, so the question becomes, how do you know you can treat an MIP? Well, the alignment of the anterior teeth tells you that. Like, this is someone you could treat an MIP. You know, and we'll look at a bunch of these, whether you can or whether you can't. Natural function. That's what you want to, that's what treating an MIP allows you to do. Once you open the bite and move the mandible to a new place, you have to recreate that. And that recreation does not guarantee you occlusal success. That's the misnomer. That's the illusion that the person telling you, yeah, you can't work in MIP, the person has TMD, you got to open their bite, you got to move their mandible, their jaw position is wrong. No, that's not true at all. They're just not capable of treating MIP effectively, right? So for them, it's easier to make an appliance, because once you make an appliance, what you do is you mute the neurology, you stop the teeth from engaging, and you get some resolution. But the person either wears the appliance for the rest of their life, or you bring their teeth back together in some way. And when you bring their teeth back together, the micro occlusion goes back to work, and it doesn't work well just because you put the teeth back together. It doesn't work well just because you put the teeth back together. This is a perfect example of that. This is a girl who's got muscle pain and headaches and jaw pain. And of course, that's easy to say, but all these pictures I'm going to show you are people that have muscle pain and jaw pain, right? And here's her alignment. She's perfect class 1. She shouldn't have muscle pain and jaw pain, right? That's the macro occlusion. That's the alignment. The alignment doesn't guarantee function, right? So you can give someone beautiful alignment, that's important, but it doesn't guarantee they'll function well, and that's what you need to understand. The T-scan allows you to take that and make it function optimally. Then you don't have the headaches or the jaw pain, or a lot less of the headaches and the jaw pain. Okay, yes.
The statement about treat patients in an MIP, but there will be, say, 2 types of patients which come to my mind. One is where there are only 3 points of contact, everything else is the open space. Then we are not going to really get them into an sort of, I'm just going to use the word ideal occlusion or ideal MIP. Does it mean that we create a new occlusion for them? That's question number 1. And secondly, how big are the chances that we just use the existing MIP and keep, equilibration is not the word as you said, but keep tweaking it with the T-scan and get them up to a nice base. So how many cases amongst 10 which come to you can be treated in MIP with no new occlusal tables?
Most of them. But the answer to your question, if you have a patient that's only touching in 3 places, that's an orthodontic patient, right? You don't have to move them. You just pull their teeth together and get them to touch, right?
So orthodontics is first before any restoration.
In something like that, right? But if they only have 3 contacts and their teeth are almost touching, adjusting their occlusion down vertically can bring all their teeth into contact. That you can test that before you do it with models and stuff like that. Those are specific situations that they're actually rare. And most of us see people, not to say that everybody looks like this girl, right? But everybody pretty much has an MIP that comes to your office. If you're making a single crown on a 50-year-old lady, she's got 25 teeth maybe. She might have lost a few, but you're not opening her bite and moving her mandible to make a single crown. That's the same principle, right? Her bite can be managed in that position, even though she doesn't have a perfect set of teeth, right? So on the whole, to answer your question, it's always easy for a lecturer to say, yeah, I treat everybody in MIP. I never have a problem with this. I always do that. You're standing in front of a room showing pictures, right? And it's not always as real as it can seem. But the truth is, I've been working in MIP and was trained to work in CR. Right? Once I started to use the T-scan in 1984 and 1985, I didn't have to move people. And people found that really surprising, because the standard of care at the time, at least in the United States, was, if you had bite problems, you had to open the bite with an appliance and find a new position and then figure out what to do from there. But with the T-scan, you didn't have to do that. So if you look at all the patients you make dentistry on in your day-to-day work, they all have an MIP, right? That person could be a TMJ patient. You can treat their occlusion in that same place as long as they don't have joint breakdown. And I don't mean clicking and popping, I mean like condylar damage and bone-to-bone contact. And those are things that we try to analyze, of course, beforehand. But a person who only has 3 contacts, you don't have to move them to a new jaw position. You just squeeze their teeth together and get more teeth to touch, or onlay them in that same position where they want to close, right? Onlay the teeth into occlusion with composite, right? And then fix it with the T-scan, right? That's a solution for a person who has only a few contacting teeth. But they don't have to be moved to do that. That's the point of this discussion, right? Because you've been told everybody needs to be moved. Yes.
So you say that you're able to sort out the clinking in the joint?
To some degree, yes.
In some situations?
Yes, we can improve. We have published studies that show you can improve TM joint health by 2 Piper classifications, which if you're not aware of the Piper classification, it's a staging of joint breakdown. Stage 1 is normal, stage 2 is beginnings of disc displacement, stage 3 is partially displaced disc that reduces, stage 4 is displaced disc that doesn't reduce, stage 5 is bone-to-bone contact. And in there are some subdivisions, but that's the general nature. So studies we've done show if you're a Piper 3A, you can become a Piper 1, which is almost normal after having your bite adjusted. So why would that be? Because when you adjust the bite effectively, you relax the lateral pterygoid and the disc can find its home again. It doesn't always go back exactly where you want it to, but I have many patients who've told me things like, well, one patient, he sticks in my brain, he was a young lawyer trying to pass the bar, which is like how you get your license in the United States, the bar exam. I have trouble passing a bar as it is, but anyways, so he tells me that he's always clicking his jaw and he has headaches, he has jaw pain. Classic youth, middle 20s TMJ person, right? Who you've seen many of them in your practice. And he has his bite refined with the T-scan. He goes through this process called disclusion time reduction, which you'll see this afternoon. And he came back over the next few weeks where we refine it a little more and you have to follow the patients for a few visits, which Ash will do. And he tells me probably 2 weeks later, 3 weeks later, I find it hard to believe that by adjusting my bite, what happened to me. I used to click 300 times a day. I haven't clicked maybe 3 times since you fixed my bite. That was in 2 or 3 weeks, right? So yes, you can, but not everyone, right? You had a question. Mostly occlusal muscle, right, exactly. And that's the common problem, right? Well, he had a question, so.
Just quickly, when we're talking about in MIP, is there a difference in how we would go about managing if somebody had tripodized cusp contacts or cusp fossa contacts in MIP, or is it just still going to be managed the same from our perspective?
Yes. Okay. The micro-occlusion doesn't know there are tripodized contacts, right? The nerves don't know there's crowns, the nerves don't know there's 3 contacts per fossa or 1 contact per fossa. The micro-occlusion responds to all the contacts. So from the standpoint of treating them, improving their occlusion, you would be picking the correct places with the T-scan to treat if that was something you were doing for that person, like de-stressing a few teeth. You'd know which parts of the teeth are the ones that are under high load by setting up the T-scan properly and having maybe even using an STL file, which you can put into your T-scan. And then you only select those problem contacts. It doesn't really matter to the organized design of the contacts, because the ideal theory about the contacts, like should you have tripods, should you have just single dots, should you have, none of that really is as important as what kind of pressure they impart and how long they are involved in the occlusion, whether it's occluding or discluding.
Do you find it effective for treating people with parafunctional?
Oh, absolutely. Yeah, we have studies that show for many years people stop clenching and grinding. The classic, thank you. The classic story of the wife who comes in after having her disclusion time fixed is, my husband, he used to wake me up, throw me out of the bedroom. I've been grinding my teeth for years. Ever since he fixed my bite, he hasn't woken me up. He doesn't hear me doing it anymore. Right? Clenching and grinding is not a central nervous system problem, not caused by the central nervous system. It's caused by the teeth. and then it feeds into the central nervous system. And these are all things that are, these are important things from the standpoint of treating someone, but that's a course in exclusion time reduction. And we give courses in that only, 2-day courses in that only, because that's a powerful application of the T-scan. That's a high-level use of the T-scan. But it applies, you can see that, like sometimes I give a course and company people, they don't really want you to ask questions about all that complexity. They just want you to learn to use the T-scan, right? But everyone wants to know about the exclusion time. Everybody wants to know, how do you fix that without an appliance? How come I haven't heard about that? Why isn't no one's telling me about that, right? And so you see all the questions are about, right? Muscle physiology, joint problems, right?
Yes.
Right. Okay. If they don't have anterior contact, they're going to have problems.
Okay, so
They're going to have excessive posterior tooth contact, which creates high muscle firing. High muscle firing creates problems for their teeth. It may not be TMD. It may be occlusal wear, it may be recession and abfraction. People that have recession and abfraction definitely have occlusal problems. You know, they don't brush their roots away. Think about it logically. They've got 2 premolars that are losing gum and bone, and all the other teeth are fine. So what do? Go home every night and say, you know, I'm going to brush those 2 teeth. And I'm going to just keep brushing those 2 teeth. You know, just brush and brush and brush, right? No, they don't even look in their mouth, right? But dentistry is telling you, no, it's toothbrush abrasion, right? These things are just so misunderstood, and the politics of it is what stands in the way of you, because you go to a course and someone tells you something that just doesn't actually have science behind it. The beauty of the T-scan, and these books prove that out, it has all this science behind it that you haven't been exposed to because of your educators. They've chosen not to adopt this information for whatever reason. And I can't tell you what it is, because I've had audiences with them all. So many university people, so many leaders in occlusion, so many so-called experts in different fields. And they just kind of say, yeah, we don't really need that. We just need the carbon paper, right? And that's not true. You need something better than the carbon paper, or you wouldn't have problems in your office with occlusion, right? And it isn't that you don't know enough. Most of you have probably taken continuums. You know, you've gone to this person, you've gone to that person, you've ground stone models, and you've worked with articulators, and you've made splints, and you've done all that, right? But it's still not solving these problems, is it? It's just not real. You can't rely on non-neurologic entities to treat a neurologic problem, and that's what splints are. They're non-neurologic entities. They're just plastic. If you do a good job, they stay below their threshold because you're controlling their neurology. But if they have dentistry done, the symptoms can come back. And I have, seen, a patient would call me, I'd see a name in my schedule. It's like 8 years since I saw them. And many of my patients came from far away because they sought out the T-scan. They wanted help with the T-scan. So they'd sit down in the chair and they'd say, ever since you fixed my bite, I was really doing great. And about 6 months ago, my dentist made me a new crown and my symptoms are coming back, right? Or they had a tooth extracted for whatever reason, bad gum health or whatever. My symptoms started to come back. Can you check it? Can you see if you can fix it? I hadn't seen them in 8 years, 9 years. And then we have recall studies. I actually wrote a 10-year recall study in 1995. I published a 10-year recall study on 102 patients. And many of those people lived without splints, without symptoms, with very low medication use, where before treatment they had all those problems you're talking about. And then recently in India, there's a very prolific researcher who is replicating all my early studies that were done at Tufts University. His name is Prafulla Tumadi, and he published a 5-year recall study on these patients that we're treating with exclusion time reduction, what we're doing today. And the statistics are very clear, how many things changed. Jaw pain, headaches, medication use, splint dependency, chewing fatigue, migraines, stress headaches, all these things way down in numbers, right? Clenching and grinding, right? So.
But why is it in a patient 8 years later, if they simply have one big filling or something, then the problems come back again?
Because they're on a tightrope. All it takes is a little bit of something to go wrong.
Fine.
And it doesn't have to be bad. It could be just.
That patient is genetically like that.
Correct.
We have to just accept that.
Yes, the people that have these problems, that they're responding to their occlusion, are always going to respond to their occlusion. So what you're really doing is bringing it below their threshold for response.
And just as a subjective number, out of every 100 patients we see in day-to-day practice, how many you think would be in that category?
If you're seeing
Just from
100
experience,
patients,
so from your experience over the years,
probably 30 to 40 are,
Out of
you know,
100?
yes, out of 100,
would be
yeah.
on the tightrope thing?
Yes, absolutely. That's just,
Wow.
you know, think about the person.
Oh, I thought you might say one.
Think about the person that you know, made a single crown for, and they just couldn't get used to it, right? And it's a small thing. It's not a big thing, right?
30 to 40.
Yeah, oh yeah. That's why there's so much occlusal disease. That's why so many of your patients have headaches and facial pain and can't chew well. And, you know, no matter where I go in the world, it's everywhere. It's every country I go to. There's always questions about the dysfunctional person, right? So there are many, many, many people walking this tightrope. Many. These different examples illustrate, you know, where you have patients you can treat and where you can't treat. This is someone you can treat. They have overlap. They have anterior teeth that strike. And this is an illusion. All of these pictures you see of people making movements to the side, you cannot see the lingual at all. So when someone comes this way, the entire lingual surface may be involved. But it looks like they disclude, but you can't be sure, right? With the T-scan, you can measure the actual time of disclusion. So this is a moment in time, halfway up the incisal edge. You know, none of us are going to go eat at the break, eat a coffee muffin with our tooth out to the side, right? Nobody. And none of us are going to go, you asked about CR, none of us are going to go out to lunch today and have someone helping us eat, putting two hands on our jaw. I have never seen it in a restaurant where someone comes up behind all these people and helps them chew, right? It's just totally illogical, right? It should be natural. And it's not to make fun of what people believe, but they believe it as if it's proven science, right? What I'm teaching you is proven science, not conjecture. It's all with numbers and metrics and data and statistics and timing values and force values and pressure values, right? And so, you know, where people need to disclude is in a 0.5 millimeter from moving to the side. And so, you know, these are pictures that are just illustrating someone's capability. Like this person, could you treat this person? You can treat this person. Why? Because they have some overlap, and then these teeth actually underlap. But you can use them. Watch what I mean, right? He can slide to the side, and the inside of these lower teeth is the guiding surface, right? He's coming this way now, right? And when he goes the other way, he has group function, right? That's the problem. When he goes this way, he has group function. See, he's only moved a small distance. That's how you can see it in the mouth. So your exam, it should not be the person slides all the way out to the tip of their canine. It's can they move a small distance and do they disclude? And if they don't disclude, that's where they're having problems, right? That's why they have problems. They don't have problems really because of vertical dimension. They don't really have problems because of let's say, poor tooth orientation. Like you asked a question yesterday about crossbite, right? The neurology doesn't know you're in crossbite. The neurology doesn't know that the teeth are backwards, right, spatially, but the backwards teeth may be banging into each other plenty, right? That's all the neurology knows, right? So this is an example of crossbite, a different anterior crossbite, but this surface can be used. If we go back to the MIP, right, if he slides, he can use the inside of, he's doing this, right? He's going like against those surfaces. Those work just as well as these would work, right? But you have to be able to visualize that. So when he comes to the right, he's on the inside of these surfaces, but he still has a group function back here, right? And this is his problem. That's why he has muscle tension. You know, group function is actually the bane of occlusion, which you guys have been told things like group function distributes stress over many teeth. That's actually true, but what it actually does is fire the most muscles. Balancing contacts don't fire anywhere near as muscles, and we'll show that to you today. You know, we can talk about the muscle physiology. We will before the patient comes. Like these patients, you know, they're very treatable because they have anterior contact, they have overlap. This girl is going to be harder to treat. See her group function? She's moved a short distance to the right. The canine engages, but because it's flared, she has entire group function. That's a harder person to treat. Yes?
In your book, you put down the short distance, 1 to 3 millimeters. Is that what you also
Yes.
being specific about? In the first 1 to 3 millimeters, that's the important analysis
Yes.
in the contacts on the growth function.
Yes.
Okay.
Just make them bite down, have them slide a short distance, and you look down the side and you'll see they're not discluded.
Yeah.
You know, but if they slide way out, they disclude. But like I said, no one is going to eat lunch with their canine to canine tip, right? You function in a very small zone, right? This person you can treat because their anteriors overlap. Centrals, laterals, and canines have the same neurology, but in this patient, you wouldn't want to use this canine against this lower premolar as a guiding surface because premolars fire muscles. So he'd be restricted to the 4 lower front teeth. This is the same girl. She's got very good guidance. She would be very treatable. This person would not be treatable. This person needs ortho in order to bring their front teeth together. If they're having a problem, right? This girl finished ortho a number of years ago. Her bite opened, this was her story, she told me, her bite opened as she grew, and as she grew and her bite opened and her front teeth began to come apart, her symptoms evolved, and now she's 28 and she has to go back into braces again. And she goes, isn't there any other way? I mean, I was in braces for 3 years. I'm like, well, yeah, you could crown all your front teeth, but is that really a good solution for you, right? That's not a good solution for her, right? So she had to go back into braces, right? So her problem is that she has no anterior contact that she can use to disclude her posteriors. It's not jaw position, right? Jaw position is, you know, I could do the same analysis. Is this a good MIP? Is it a bad MIP? Like, should we open her bite? None of these people do it. Did I have to open their bite to treat them? I had to close her bite to treat her, right? Not open her bite. This person is very treatable. Not because they're class 1, but they have all this overlap, 50% overlap, and they, you know, they're, you know, easily can be treated to move laterally. The canines are flush. So this is another example of, well, this person should have anterior guidance, but they when you measure them with the T-scan, they do have anterior guidance, but they don't disclude fast enough. And I don't mean fast in speed, fast in time. They drag over their back teeth. So why do people not disclude when they have anterior guidance? It's something no one's ever told you. I might have a slide of it, but I don't think it's in this course. It's because the disc is soft. And if you think about your head, if you go to bed, you put your head in the pillow, what happens to your head? It sinks into the pillow, right? When the mandible moves laterally, the muscles contract, which pulls the condyle up into the disc. The disc is soft, the condyle elevates, and as the mandible moves, it keeps the back teeth rubbing together because the back end is high. The front teeth are too far away to be able to separate those teeth. So this person may separate late in the movement, but not in the beginning of the movement. And that's where it counts. It's got to be in 1-2 millimeters from the central fossa, just what you were asking about. Anytime you have forward lower anterior teeth, like a few that stick out or one that sticks out, you know, something like that, you always have a dent in the smile, okay? Or if the lower anterior go like this, you'll have a dent in the smile. Right?
In a case like that, you've got to commit to the treatment because there's no test drive or anything like that, is there, in this sort of case?
You could, you're right. You could try to bond in like as a template. You could try to do a composite reconstruction and, you know, not commit the person to it. You know, it's stuck there, but you can drill it all off and you can see if it helps them, right? And then when it helps them, so what you would do is, let's say you said, I want to test it out. I'm willing to let you bond my teeth. So you create overlap, you bring the teeth down, you get a guidance mechanism in place, then you do the disclusion time reduction with that as a guiding surface. You have the symptoms go down, or you certainly in this case, in his case, it's more about saving tooth structure. I don't know if he's symptomatic or not, I forget. But if someone comes like this to you, the only way you can stop this from continuing to progress is to disclude them, right? They have to be discluded or they're going to lose all these teeth, right? So you then free them up laterally with the new guidance in place that you actually bonded in and created. And that would be with like composite veneers and, you know, you'd plan that in advance prosthetically. I think it would be more up to the patient than to me. If they were on board for fixing it, could go right to completion, because they might understand the mechanics of leverage and the fact that they need their back teeth to come apart and they don't want to go for a test drive. But someone else may be like, you know, it sounds like I need that, but I really don't know what it's going to feel like, and I'm afraid to have my teeth touched even though they're ugly. I'm not sure I should do that. I might need root canals. I might need this. You know, so there's it's not that you couldn't go straight ahead, but there's a patient component to it.
So it's two things: the patient component and the confidence of the dentist to do it.
Yes, yes, but you could do it with veneers. Yes, you certainly could. I think we even wrote an article. One of the guys who used to work for Rosenthal Aesthetic Advantage, I think he wrote an article about doing very much that kind of thing, closing an open bite and doing it with veneers and then discluding them from there. Okay, so in other words, you turn the system on, nothing happens, the sensor is waiting to be bitten into, and then you bite into it. That is not how you want to record, and there's a number of reasons for that. One is you might miss some early data. The other is, if you're going to work with the EMG like we are today, you need to have lead time. You need to see resting EMG, the person bite, the person make an excursion. And that lead time, if it isn't there, it cuts out the resting EMG. So I'm going to show you what lead time means in a second. So you uncheck triggered start, and actually to activate this page, you need to have your handle plugged in to your computer, and you need to have a sensor in your handle. So you can't adjust these settings without that. Okay, so you might come to this screen and these boxes will have checks in them and they'll be grayed out and you can't fix them. That's because you don't have a handle in and a sensor in the handle. Okay, so that's very important. Then you want to check show all excursions in quadrant view. Okay, quadrant view is where you divide the force plot. Instead of it just being right and left like down here, this is red is right, green is left, you divide it into anterior right, anterior left, posterior right, and posterior left. And the reason you do that, and you'll see it, we're going to do it with this young lady who we're going to scan, is because it allows you to see excursive function separating the anterior component from the posterior component. It's a very important diagnostic entity. It changes the graphing, it changes a lot of things that are, it's not worth me talking about it now. You're going to see it when we actually record on her. Okay, and that will make it understandable why you want to do that. But this way, what happens is when you get a movie back and you label it as a right lateral, automatically the quadrant line will come on. And then you adjust the height of the quadrant line to match the patient's anatomy. But so this way you don't have to find the quadrant line, you don't have to wonder which tool do I find it under, you don't have to do that, okay? You just label the movie, protrusion, right lateral, left lateral, the quadrant line comes on, you're good to go. The rest of this, actually this is an important one too. Remove, typically these two, using a large cursor and display COF by closure. COF is it's blocked on this screen, but it's this kite, people call it the kite that moves around the screen. If you choose this, you only get one kite per bite. So if the person makes 3 bites, each kite applies to that bite. If you don't check that, all the kites overlap each other, and you can't tell is one from which bite is which one from. So this is a very important one, but usually the software comes with that set. This box, show erased forces, uncheck it. If you have to erase something, like why would you want to erase anything? Okay, so let's say the sensor folds up over the front teeth and there's excess data on the buccal aspect of the central incisors because the sensor folded up because the bite is very deep. You don't want that information. It's not real, right? Or sometimes you'll have a slight anterior open bite patient like this, and there'll be anterior contact because pressure is what's being measured with the T-scan, not contact. So as the mandible moves into place and momentum brings it into the teeth, some of the low forces can show up on the anterior teeth even though there's no contact. So you look in the mouth and you say, you know, there's no contact on number 7 or number 2-1 and number 1-2. I'm going to erase that, right? So when you erase it, and I can show you how you do that, if you show erased forces, it'll still be on the screen, but in like a gray color. You don't want it on the screen. You don't need it on the screen. It's going to mess up what you're looking at. So you just don't want to see it at all. Show erased forces. Another thing you can erase is a break in the sensor. Yes.
Quick question. on that topic you just mentioned, if there's no contact, how can you measure the pressure and show up on the thing?
Because of momentum, right? The sensor is being
Okay.
bended around the front teeth,
Okay,
right? There's a bend around the front teeth, and you actually can get low forces, not forces, but low, let's say, sensor response because of momentum, and that also has to do with sensitivity. The lower the sensitivity within reason, the less you're going to see those flaws. Okay. The reason you get extra data that doesn't belong there, other than something like the sensor folding up over the teeth or being bent by the cheek as the person moves in one direction, is because of higher sensitivity that sets off a response. And I'll show you what I mean when I'm going to record. I'll rub the sensor and push on the sensor and do stuff with the sensor, and nothing will come up on the screen. But if I have the sensitivity up, I can just rub the sensor and data will come out. So you get these flaws that don't belong. Like none of you were there yesterday. You were there yesterday, but the patient we had, a dentist who volunteered, he used a large sensor because it fit his mouth, but he was getting some data from as he would move around, the back of the sensor would bend, and he would get a little false data in the back of the sensor in a place like over here, like against his throat, where there was no real data. So we erased it. And because any data that doesn't exist affects your total force. Like if there's a blue column back here, it's adding to this left posterior quadrant, right? So we erased it. So there's a lot of reasons to erase. And you can break the sensor. If any of you have ever seen a perforated sensor, you get this massive spike in force. You can erase that out, and you still use that recording. You can't use the sensor anymore, but you can still use that data. Once you erase the perforation, the graph fixes. You get a normal graph form instead of a bad graph form of a perforation. And these are important things to be able to understand. So we might see a perforation today, we might not. We can try to cut the sensor and show you what one looks like, and then I can show you how to erase it. Yes. So it's not an absolute. But what does come up every time once you set it up correctly is the dental arch. So that's why it's so important to set up the dental arch. You get the dental arch right, and then every recording you get the data back on the dental arch is going to be very close to what you want it to be. So that's that, but not things like erasing. That it's recording to recording. And then, okay, so that's the advanced tab. Okay, good. Any questions about that? Okay. Now, lead time. This is what I was talking about. When you have triggering on, you have no lead time. You see the data starts at 0 time and 0 force. This is force percentage, this is time passing. Lead time is very important in terms of not missing data, because the data only comes on when the sensor is activated. And here's lead time. See, I turned the sensor on, 1.2 seconds passed before the patient started to bite down. Right? So this is a correct recording. It's not that this recording can't be used, but this is going to miss some data. And this is an example of actually a very complicated movie that you also shouldn't do. Meaning, you don't want to have 2 bites and an excursion in one movie. How do I know that this is an excursion? This is what an excursion looks like in the 4-quadrant graph, okay? And a skill is to be able to read this mess and know what it means. And we'll get into that when we go through it with our patient. But this is 1 bite into MIP that the patient didn't really make. They only bit weakly, then they bit firmly, and closure movies look like this. And you always want to have this rise, hold, open. Even in an excursion, rise, hold, slide. Okay? That's how you get good data. If you don't have these shapes in the graph, you don't get good movies. But this is not a good movie because the patient can't do all these things well, right? So generally you make 1 or 2 bites, that's one movie. In an excursion, you make 1 bite, hold, and slide. So this itself should just be one movie. Okay, yes?
What's the amount of time you hold for if you have to measure it on the stopwatch?
Well, actually, I've never quantified it. The skill that you need to learn, and you've probably learned it because you've learned to record, is to see the data evolve and stop changing. Once it stops changing and you can visually reference that, then you have the person open or slide. And it's not something that's hard to do. You'll see it when we do this recording on this young lady, the patient will bite down and all these columns will quickly rise and then everything will stop. And as soon as you see it stop, that's when you have them do the next thing, like open and rebite.
It can vary per patient.
It can vary per patient. This, for example, this person, in this first bite, it took a long time for them to actually get to their full contact, which is actually a very weak bite. Anytime the horizontal line, the red line, the black line, travels slowly to the top of the graph, or the top of the curve is actually better because this is not the top of the graph. This is a weak closure that the patient is struggling to do. Now compare it to the second one where the graph line goes straight up or almost straight up. That's a very fast closure. That's much better data to work from. But if the patient always does this, that's their dysfunction, right? That's, if every movie you make, they struggle to get to full contact. Like in this one, they bit much harder, but let's say the black line went like this and then like this, right? That would be a struggle for them. And if you see that curve in every single bite, they're struggling to close. That could be muscle strain. It could be there's a tooth that's sore that they're trying not to bite on. It could be that one side hits much harder than the other and stops them and they have to squeeze the other side together, right? There's a lot of reasons that you get aberrances in the black line. But this is an example of a weak, slow closure. This is a better closure, and this is the best closure. So the more vertical the black line is, the better it is. Okay, good.
You mean the A-B column?
Right, well, the A is first contact. B is static intercuspation. So this is where they bite down. Between A and B is where the loading of the bite occurs. So that's where all the teeth are rising into pressure. Between B and C is where they hold their teeth together, and at C is where they make an excursion. And D is where they disclude. So these are all things that you'll see in great detail today. So this is a graph of a dysfunctional patient. You see they're very slow to close. This line rises very slowly. I'm forcing them to close. I'm telling them, no, squeeze harder, squeeze harder. They squeeze to full contact here. B is static intercuspation. Static intercuspation is where all the teeth come together and stop meeting. Maximum intercuspation is where they squeeze that together, the last 7, 8, 9, 10%. So this is static intercuspation. Then they squeeze to maximum intercuspation. Then they held their teeth together, and here they went to the right. And I know they went to the right, well actually, yes, they went to the right most likely because the red quadrant takes complete control over this excursion. The posterior quadrants, the blue and the orange are the posterior quadrants, and you see the blue quadrant travels along for a while, the orange quadrant travels along for a while. So from here where they started moving to here where the posterior quadrants reach zero is the disclusion time. When this is very long, you have a lot of muscle firing. When it's very short, short meaning short, you have much less muscle firing. And you'll see that with our patient this afternoon. Okay, let me see what this is. Lead time, right, okay. Okay, arch model setup. Well, we're going to do it with her, but you must match the arch closely to the patient, and you must include where implants are located. It doesn't matter, you'll see, when you look at the list of things, and we'll do it with our patient, it'll say pontic, abutment, crown, inlay, onlay, missing open, missing closed, implant. The only things that matters are implant, missing open, and missing closed. If you want to label a crown, okay, but it's not going to change anything in your data. The things that matter in the data are missing teeth, whether they're an edentulous space or a closed up arch where the premolars are extracted for ortho. That really matters because the arch doesn't have a missing tooth. It has no edentulous space. And implants. Why implant? Because you get an implant warning only if you label the implants in the dental arch.
Robert, what
Yes.
happens if the gap is very small, a quarter of the width of the tooth? Do you put that missing open, closed, or what? If it's not.
That's a very good question. You would make that missing open,
Yeah.
and you would measure that space with a caliper or perio probe,
Yeah.
and you would enter the width of that into the dental arch. And I'll show you what I mean about that, so that you can see that there's a gap there, right? Right? Yes, okay, so correct the T-scan dental arch in each recording. you look at the data when it comes back, and before you do anything else, you make sure the data matches the arch. And after you set it up pretty well, it will. But you might have to expand the arch a little or squash the arch a little to fit the data. And that's something you have to see to understand. Let's see. Okay, so this is really chairside clinical information. So let's say I was going to deliver this composite, turn it into a prosthetic. Today's the day of delivery. The digital scan, as this doctor, what's your name? Mark said, is hard to match, right? It's a great tool, but it's hard to match. In the middle of a big delivery, you don't want to be matching it. You want to use the dental arch that the T-scan gives you, because if it doesn't match, the prosthetic arch doesn't match so well, you're going to waste a lot of time trying to like match it, right? So the best way to use the digital scan is to scan in advance, load it into the software, take a movie that is an old one, that's the same patient, put that data on that arch, match them together so it's set up correctly, then have the visit. Don't try to match the arch while you're doing the delivery. It's too much time. You waste a lot of time. Okay, so if you can do it in advance, it's perfect. If you have to do it at the day of delivery, it's a little difficult. Right, that's just what I was saying. Simpler to adjust the T-scan arch to match the patient. Okay, and you can line up the digital arch before, which is what I said. And let's see, so this is entering information. See, I'm entering implant, implant, missing open, missing open. Notice I didn't enter crown, abutment, just where the implants are. And these two are overloaded. And so this is a typical variable bite. The person was scared to close, right here. They're slow to close. I made them squeeze by talking them into it. They held their teeth together, they opened. The second time, they weren't scared to close. They just went ahead and did it, right? And this is very useful information. A single bite, so you understand how the T-scan works, every level of color you see is based on the moment that's equal to 100%. So the software calculates in the middle of the scanning where the 100% moment is, and everything else is graded off of that 100% moment. So you really only want 1 or 2 pinks at 100% moment. But people don't bite 100% all the time. But if you make a 1 bite, which could be a weak bite, the patient will get back a 100% moment. Even though they bit weakly, it's still 100%. Somewhere in that bite, the data that was generated is going to be 100% of all the data that was generated. And then the software produces it for you, graded based on that. If you make 2 bites, one might be better, one might be worse. That's what you're seeing here. This one is better, this one is worse, right? And that helps you choose better data to analyze, right? Go ahead.
Is that one on the right better because of that classic bell shape? It's rising, going across and coming down?
Yes, that's better. This would only be better if this happened every time. Okay. Remember I said that? If you see this kind of slow down or a weak vertical curve, that's every recording, it's there. That's the problem. The patient can't do what you want them to do as well as they should be able to do it, right? So making 2 bites, you'll always see that. Now, some people want to make 5 bites, 6 bites, 7 bites. Like there's a lot of the Italians, they want to make all these bites and all these excursions in one movie. I don't know why they believe that in Italy, but maybe it's how they register occlusion in chairside. But it's a complete waste of time. The patient can only do a few things well before they tire and fail, right? And what happens is the graphs get compressed and compressed and compressed, and you can't see the detail in them because the more things you make, you only have this much space to display it in. So if I made 7 bites, they'd all be compressed down, right? And the time frame would be very long. And so you can't see the detail of things like this very well sometimes. So you only want to make 2, 3 things per movie. And generally I only make 2 bites, and all the excursions are made as a single event, not bite down, hold, slide left, open, bite down, hold, slide right. The Dawson technique for looking at excursions in someone's mouth is to have them move left, have them come back in, have them move right, have them come back in, have them go forward, have them come back in. You don't want to do that with the T-scan. It wastes a lot of time, and the person never does the second and third movements very well. So every excursion you want to record is a single event. Bite down, hold, slide. That's the end of the movie, okay?
All right.
Yes.
With the multi-bite, do you normally record only 2 rather than 3?
I only do 2, right? But you can do 3. But the thing is, if you do 5 or 6, the person is just getting tired. All they're doing is biting into the sensor, getting tired, right? That doesn't help you, right? So you want to make only 2, maybe 3. And this is just to show you the same thing on the bottom, right? We loaded, this is the lower arch, there's the labeling. Okay. Okay, so we're going to talk about recording sensitivity. We're going to record on her. What is the sensitivity really doing? You're fitting the patient's bite strength to the electricity that's within the sensor, so you get a clean recording without having too much false data. And that's really limiting the number of pings displaced in those little squares on the sensor. The amount of electricity that's actually being displaced is called the digital output. The digital output varies. It's like 2 volts, 5 volts, 7 volts, 50 volts, 47 volts, all going on at the same time in different parts of the sensor that the software and the handle scan and report to you. And it's instantaneous almost. It doesn't take too long for the software to process all these, hundreds of moments of digital output changes, right? So and there's actually, you can go and see the digital out. I can show you where you can see the actual digital out in your sensor for frame by frame by frame. So people that do research, they go actually under the colors and they use the electronic values. But the digital out of pink is 255, no matter how much is in there, right? That's why the T-scan shows you 256 levels of force. It peaks out at 255, but it could be 1,000, but you just can't be red. So, meaning it can't be not red as in red color, red as in understood by the software. So the digital output stabilizes around the arch, meaning it becomes more constant in each cell if you crimp the sensor a few times, which is where you are basically having the patient bite on the sensor to test the sensitivity. And we're going to do it in a minute. You want to look at the screen and say, how many pinks is that patient generating? If there's 7, if you can quickly count with your visualizing the screen, 5 pinks, 7 pinks, you got to turn it down. If there's no pink, you got to turn it up, right? And you want the patient to bite hard because that gives you better data at lower sensitivities. Reduce the sensitivity to no more than 2 or 3 pinks, and if you set your error message, it will tell you that you have 5 pinks, 6 pinks. We saw it yesterday. Lower is always better than higher. Okay. That's really important to understand. You don't want to jack it up to get pink. Like if you have to go beyond the middle of the scale, you all have the T-scan, so you know the sensitivity scale is at the bottom. It says median or medium. And once you get to the right of medium, you're going to get a lot of false data. So let's say the person can't generate any pink and you're up to medium. Well, maybe you'll go 1 more beyond medium, and then you'll see if they generate any pink. But if they don't, you can use red as the highest force. You can use yellow as the highest force. It's better for you to use less sensitivity than it is to get pink on the screen because you went all the way to the right of the scale, because that means you're going to get a lot of false data. And what happens is all these colors are magnified, so the data looks like very green, yellow, orange, instead of looking mostly blue with a few isolated pinks, reds, and yellows. That's a good set of data, and you'll see what I mean. The 100% moment is at the height of the curve, and you can get there if you want to check 100% just by going up here and choosing maximum force. I think it's view maximum force, right? That'll take you to the 100% moment, okay? This is too much pink, okay? And this was if I was going to show you the real movies. You'll see some slides with some names of movies that are really good examples of the right thing and the wrong thing. But we don't really have time for that. We're going to do it with a patient instead. So this would be a really bad movie, okay? There's way too much pink. And the other thing that happens when you have way too much pink, which is very important, is balance is almost guaranteed. Almost guaranteed. The more active the sensor is, the more false you get the balance. So you want to have very few pinks and you'll get a much cleaner representation of balance. The other thing that's wrong with this movie is if I was going to look at this excursive function, the quadrant line came on when I labeled it left lateral. It came on in the premolar area. It has to be moved up to between the canine area. And I'll show you that when we do with our patient. You don't accept where the quadrant line comes on. You want to, and then there's something else wrong with this movie. The data doesn't match the patient arch. See, there's data in the third molars that don't exist, right? So this movie has to be modified before I would actually analyze it. Although it's not a great one to analyze because the data is bad, right? But these are things to notice, right? Does the data match the arch? No, there shouldn't be any data in the third molars. So what I can do is take this tool, this is called the central incisor width tool, and I would open that up and I'd increase the central incisor width until the data marginal ridge, the second molar marginal ridge, ended up here and ended up here. And that would expand all these teeth a little bit. And then once the data was correct here, I would move the quadrant line up. I don't know if the next slide shows it. No, I don't. Okay. So if I made this smaller, right, for whatever reason, then the force percentage is going to go down. These force percentages will probably go up because it's going to encompass, the 1,3 is going to encompass some of this data now, right? Say this pink and red zone was actually here now. That means that data would be part of the computation of the second molar, right? So yes, that matters a lot. So it's the reason that, and it's a very good question, both of you, the reason using the central incisor width tool to expand the arch is so helpful is it stretches all the teeth uniformly, as opposed to me dragging this marginal ridge down. Right? If I drag this marginal ridge down, I've made a very fat second molar, right? But that's probably much bigger than the real tooth, right? So by using the central incisor tool, this line will move, this line will move, this line will move, all the lines will move. And then you maintain that harmony, right? And that's in the generic T-scan arch. You can use it in the STL file, but in the STL file, you can see the second molar underneath. You just drag the line to the distal of the second molar. You drag this line to the mesial of the second molar. You drag it right over to where the teeth are and you separate them. And we'll do that now because we have an STL file. We're going to find her digital arch, okay? But before we do that, we're going to ask her, so which teeth are you missing? Are you missing any teeth?
That's a question.
Open and look up.
Bring a mouth and just check.
Just open, I can look.
We'll just have a look.
Right, so she's missing premolars on the top, and we'll just do the top.
And premolars on the bottom.
Yes,
as
well, we're just going to set up the top arch.
Yeah.
You would set up both arches if you wanted to. Typically, if I'm doing a natural tooth patient, I really only focus on the upper arch. It's a better arch to work with. But if I was doing 14 units of crown and bridge on the bottom, I'd be entering a lower arch, okay?
Is that just because it's in one stable position compared to the lower? That it's a better arch to work with?
The orientation for me works better. The lower is oriented it's the same, it's a horseshoe, but it's like I am visually better at the top. And for many years, there was only one arch. I think I got used to that. In the early versions of the T-scan, there was only one arch. So I became accustomed to that. But certainly if I was going to put in something on the bottom, a bottom denture or bottom crown and bridge case, I would be using the bottom. Okay, so she's missing premolars, so we'll call it the 2-4. That's missing closed. The arch is closed up. So we'll do the same thing on the 1-4, missing closed. And then she's missing 8s, which would be missing open, because there's no closed arch, which is missing, what I do? Right, missing
Give you a
open.
chair?
No, I'm good, because I'll be standing anyways.
Okay.
And missing open, right. And then I'll just put an implant in for the sake of, maybe having an implant warning show up. I don't know if it will, but match her, right? And that way we can make some changes if we have to, okay? And that's just to illustrate to you. The other thing you can do, and this is I didn't show it to you. If you had a turned premolar, like totally wrong in dimension, every number you have here is based on that 7.5 number. So watch what happens. Look at those boxes. If I type in 8.5 and then I go enter, all those numbers change, right? So putting in the central incisor width, the other numbers are all tied to it by the rule of golden proportions. But if I had a premolar that was turned sideways, like let's say the 2-4 was in the wrong place, maybe it's actually 9 millimeters. And I would measure that with a caliper. If I plug in 9 and enter it, it'll take it, right? I'm going to put it back to 7 for the moment.
Is that the same way you put in information with the space between the teeth?
If there was space between the teeth, so that's a good one. So let's say she was missing the 2-5 or the 2-4, was extracted, but it was a really small space that didn't get totally closed up. So we'd say missing open, and then we'd shrink the space down, so that would be the 2-4, which is here. Maybe it's 3 millimeters wide, okay? And that would be the the edentulous space. So if I do that and I pull up a movie, you'll see her arch. Okay, see there's the small space, okay?
So the optimal way to use this would be to measure all the teeth and literally put in the exact width. It would
Ideally,
be optimal.
Ideally, right? And you can do that. Or you can get a staff person to do it. But I can tell you, I only do that when there's really strange things. And the rest of the time I go with an approximation. And certainly with the STL file, you don't have that issue. We'll put the STL file in and we'll get a data set back and then we'll match it all up, okay? So that's what you would see, right? And then you shouldn't have much data in this area, right? So if you actually scanned her and then there was like overlap of like an orange or a red in here, you could drag this in the playback, you could make it smaller so the data is just next to it, right? And these are very important things to do because that is much more accurate than if you have data in a edentulous space. Although force spread can go beyond the tooth, right? Force spread is not contact. It can actually leak over the marginal ridge down the side of the tooth. We don't know that it's doing that, but the sensor can pick that up. So, maybe a little bit we'd keep some of the data in here, but not the whole. If there was a whole data set in here, we'd have to adjust that. There shouldn't be a whole data set in there. All right, let me go back and fix that.
Change it on the arch as well.
Not here, not in the recording screen, but in the playback. Like I can't do anything to this now unless I go back to here, edit the patient, take out that edentulous space, missing open, change it to missing closed, which is what it was, okay? And then when I make a new movie, which it's not letting me do, let's see if it'll pull one up. Let me see. I'll have to put a sensor in to do that. All right, let's get her STL file. When it comes up to record, you'll see there won't be any edentulous space there anymore. Okay, so now we're going to have to edit her patient again. Oh, that's why. It wasn't highlighting her name. So here you'll get to see. See, now it went back to what it was, okay?
The implant is highlighted as a red I-16.
Right, and any one of those things you put in, like veneer, abutment, pontic, it'll turn the number red, but it'll just say 1.5, it'll be red. It won't be I. The I is for the implant.
And also, always we are looking at the arch from top end of the head so that the right is actually on the right.
You can change
You
that.
can change it depending
You
on
can
the
flip the
settings.
arch. I don't think you can flip the arch in the recording screen. I think you can only flip it in the playback. So, if you like left on the right and right on the left, that's your preference, you can. Okay. All right, so let's go get the STL file, okay? We'll close that up. We have Niru's name highlighted. We can edit the patient. Let's find the STL file on the top, which is in this.
Top one. It's there.
There it is. There it is, okay, without ditch. And then when you have it there, whoops, I got it there, and I say save, sorry about that, it's there. It's going to tell me that the file is too big, and the software is going to modify it to fit it into the T-scan data. It does it pretty fast. Now, in the recording screen, it won't let us see it. The recording screen is always the generic T-scan arch. It comes up in the playback. Okay, so you see yesterday's patient, the sensitivity was very low. Some things that are going on here. I don't have a sensor in place, so this is red. But even if I put a sensor in and it's not put in correctly, this will stay red. Okay, that corresponds to the handle having the green light that you see says my handle is active. So the first thing is to actually look at the size of the support that fits the patient and not to just randomly say, yeah, she's a small, she's a large. You don't want to come at the patient with the sensor until you actually have the right size. So you have two sizes. So I'm going to place this around her teeth. I want to make sure it floats. And this floats for her. This is good, meaning that it's not binding on her second molars. Bite down for me. You can bite okay? Yeah. It's not stopping you? So what I was asking her about is, was this sticking in her ramus? Was she hitting the inside when she was closing? If she was, we'd go to a large. And if the large was too big, it would stick into a ramus, right? But this will work for her. She's a little lady. Okay, so then we can now start the recording process. So the sensitivity is a little low. Let me find a small. Like I said, here I'm putting the sensor in. I'm really not putting it in completely, but I'm locking it into place and I'm showing you that it's not working.
Yeah.
right? If I almost put it in correctly and lock it in, it took it, right? Right? So now it'll work, and then I usually go like this just to make sure it's going to work, okay? And then the first thing I'm going to do is look at the sensitivity. I'm going to raise it a little. I would expect her to need a little more electricity. So I tend to start in the three or four. I'm going to make it a little darker so you can see the screen. So I'm going to do it as if it's behind me because that's harder to do.
Would you
Okay.
prefer the patient not to see it while they're doing it themselves?
Doesn't matter. Doesn't matter. Although you might want the patient not to see it when it says your denture is 75 right, 25 left, right? A lot of people have the big screens up in front of the patient or the one up above above their head, and it's right there saying, why is it so unbalanced, Dr. Kirsten? I knew there was something wrong with it. It just didn't feel right. So those are the, so you have to weigh that, where you have the screen. But from a standpoint of using it, direct visualization makes it much easier because the technique is you place this in the mouth, rest it on the front teeth, so this is really touching the front teeth, and then you look at the screen before you do anything else, and then you activate the movie, right? And you don't want to be looking at your hand, like I said. That's our big problem. Okay. Yes, and in a dental chair, she would be a little bit back. So the fact that she's leaning back like this is actually very good. You don't have to lean that much, but that's okay. So I'm going to rest on her front teeth, and as I said, I'm going to look behind me to exaggerate that I have to look. Okay, bite down hard for me. Squeeze hard, squeeze, squeeze, squeeze. Good, good. Do that again for me. Bite down hard. Good. Open, open. Bite down hard. Squeeze hard, squeeze hard. Yeah, good. And open. So we can use that, right? That's 3, 4 pinks, maybe 2. She's struggling a little to hold it together. That's why it was fluctuating. But that would be a good level, right? It's not so easy for her. And you're going to see some fluctuations in the black line because of the way she's not able to hold her teeth together. That was good. You're right on target. In this moment, I'm only looking at the amount of pink. And I'm asking her to bite hard. You see how I coached her into squeezing harder, and then she got it, right? You saw the first time there was 1 pink. The second time there was 3 or 4 pinks. She now knows what she has to do, right? But the thing is, you don't want to have them bite 15 times to get the sensitivity because her jaw might get tired. Her bite might hurt a little to bite on. Like you said, there's a tooth that's a little sore on somewhere on the left side.
Left, lower and upper.
Left, lower, and upper. So that can give you a guarded attempt. The patient knows they're going to feel something and they may not actually close as well. So we talked her into closing harder. And the second time, she gave us 4 pinks. So we'll keep it there just because she's got a few issues that she's a little uncomfortable. And we want to make sure the sensor is a little bit easier for her to bite in. But I can tell you because of the way the columns are bouncing like that, that means she's struggling to hold her teeth together. And so we'll get that data even with the 1 extra pink, right? We're going to see that regardless. But that's important that she gets a chance to recover. So, sometimes I'll go to an office and the dentist will say, yeah, my hygienist, she makes all the recordings. So I go in and watch. Patient bites down. She opens. The girl doesn't even let the data recover. She's back in there. Now bite down, slide left. The data comes back. She now bite down and slide right. There's no way the person can do a good job, right? So you need a little downtime, right? It's just like weight training. If you go like this with the barbell, right, you got to put it down before you can do it again, right? Biting into the sensor, holding the teeth together is a muscular exercise in its own right, okay? All right, you ready? We're going to record that. So I'm going to exaggerate the thing again. You stay like that. That's good. I'm going to rest my head right there. So I'm going to turn around and I'm going to hit the button. Go ahead, bite down for me. Squeeze hard, good. And open and squeeze hard again. Bite down, squeeze hard and open. Okay. So the second bite had 3 pinks, right? The first bite had 5, so we're going to get an error message. There's my error message. That's the setting I told you about. Now, do we have to throw the data out? No, we can still look at the data. So let's look at the data and give her a chance to recover. And then the next movie, we will turn it down 1 notch. We'll go down 1. Okay, here's the digital latch. Right, we get to fix it up. So let's see. Manual adjustment. So you guys can watch this. First, I've got to rotate it down for me, like this way. And I've got to turn it around. So I'm using the rotational tool. So I got to turn it around and get it into place. Depending on the version of, it's a really nice scan actually. You can see it's very beautiful. Okay, now we're getting somewhere. So you see I'm just rotating into place. Now what am my frame of reference? I'm going to try to line up the midline. Okay, I'm also going to put the data on, which is going to help me orient it a little bit. Now I'm going to use this tool, and I'm going to move it up. So we know that this is really, assuming that everything is correct spatially, this should be in the 2.6, 2.7 area. She has a 2.7, she has a 1.7. This side is much shorter, so we're going to have to rotate that out a little. So I'm going to try to make the screen get bigger. See, I'm making the screen get bigger. I'm getting closer to it. I may not be able to match this one. We'll see how we do. I'm pulling it towards me, down towards me, and you see I'm getting this 1.7 data to kind of line up now. All right, the 2.6 area, 2.7 area isn't lining up, so we're going to rotate this. See how the midline now lines up. This was a tough one. So this is what I was talking about, chair side. Do I want to do this when I'm delivering this case? I want it set up in advance, right? So I'm almost there, actually. I might be able to get this. And you can go in the mouth, too, and you can mark with carbon paper and say, okay, well, maybe this is just the mesial half of the 2.6, 2.7. I'm sorry. We're going to move the numbers in a second. I'm just looking at the colors where they are on the teeth, and I'm trying to center, let's say the midline should be something like that. So I've got to rotate a little.
Robert, this is where my confusion is. We are aligning the 1-1.
The 1-1 and the 2-1 midline with the T-scan dental arch. This is the T-scan dental arch. And then I'm trying to get the size of it to fit the existing size.
Is that not the 1-1 which is now sitting in the 2-1 space?
Well, as I said, I'm left, right. Someone else might like it backwards. Once we align it, if we want to flip it over, we can. You know what I'm saying? This is how I like to look at it. But you might like to look at it, let's see if it'll do it, like this. Right? It flips it the other way.
Now, yeah, now the 3D model matches. Correct. Now the 3D model matches the...
It matches the way you want to see the data, right? It doesn't match the way I want to see the data. Meaning I like it the other way, right? So it still matches, right? It's all your orientation. I'm looking at, this is the patient's left, this is the patient's right. That's what matters, right? But you might want to see it the other way. You can choose to see it the other way, right?
Yeah, what I'm trying to understand is the STL, this is the patient's right, yeah, Robert?
Left.
That's the
This is the
patient's.
patient's right.
On the STL.
Yeah, on the
On the
STL.
Oh.
It's an
On the
example
STL.
here.
That's what I'm trying to see. Why are we putting the
Oh,
T-scan,
then-
reverse? Yeah.
It was just the way I found the arch. In other words, I flipped it over, but you would know that. So I'd have to, let's see if I can do that, how I can do that. I don't think I can flip it that way. I can only look at it in this way. I don't think, I wonder. That's a very good question, actually. That could be a flaw in the software.
Flipped it, yeah? So if you
Right.
flip it, it will just match.
No, but if I flip it, it flips both of them.
Yeah,
It does.
flips both of them.
It flips both of
Only
them.
the STL flips.
It doesn't flip the data alone. It flips the STL
Flips
file
both
alone.
of them actually.
So in this instance, so that's an interesting thing because I wouldn't have known that because I'm not really looking in the patient's mouth specifically. In others, I might if it was my patient, but I'm just trying to show you how you can line it up. But if that happens, then that happens a lot, then that would be a flaw in the software. That I wouldn't be able to fix that, right, without the software fixing it. So this is actually going to be a good thing it's in my computer. So what you're saying is this is the patient's left side, and this is the patient's right side.
Correct.
And I was not able to orient it in any other way except this way. By, in other words, the way the STL file was brought in by the software, right? So that would be a problem in its own right. And if you knew that, you'd have to take the arch off. But we can
Unless you
actually,
rotated it 180 on that axis and looked at it from the palette, like
But-
the head down view. So if you rotate that 180 degrees, you'll see like the grayer side, the inverse of the STL file.
But then
And
what's,
could you
what's the
align-
use of that? Because we want to see the marks on the...
if it shows up that way, that's going to be interesting.
So if you flip it instead that way,
All right, now let's try it.
yeah.
Yeah, there's nothing but black,
Okay.
right? That's not going to work, right? So that's interesting. That I'm glad you guys pointed that out, because I would bet the engineers would not assume that that would be the case.
So is it definitely flipping the STL as well? How will you flip the STL? Because yeah.
Well, it's the way it was brought into. It's the way the software saw it.
So unless you pre-flip it before you
Well, in this instance,
that
if it's a real bug, that would be a way around it.
export the file.
Okay, so I'm not concerned about any other embrasure but the central incisor embrasure. In other words, I'm trying to line this up. And then I'll rotate it just a shade to the, try to get the things in the middle of the teeth a little. Something like that. Yeah, we'll keep it like that. Thank you for telling me it was correct, because I would have gone back to the
No, this is
software
correct.
engineers. They would have been like, oh no, we have a big problem.
No, this is correct.
Okay, we'll keep it like that.
Yeah.
That's you know, I would assume then that means also that the 2.7 doesn't have a counterpart. Let me see. And this might be something that we would erase. Okay, so the next step, we keep it there. And of course, we can play with it a little more and make it more permanent, but for the moment, I think it's better that we look at our data. Now I'm going to move these marginal ridge lines to match the prosthesis. This way, when the dental, if we don't use the digital display, we have the right sizes.
Perfect.
On a day-to-day basis, what's your advice? Do you import the STL files or just get on and do these kind of...
You know, as I said, if I can do this relatively quickly, it's of tremendous value, because you know that that's the marginal ridge, you know that that's the distal fossa, you know where you're going. But again, if it takes a lot of time, let's see if we can just pull it down a little. So I only use the manual adjustment. I don't use the other options. I'm just going to pull it down a little to get that 2.7, right? Something like that. Okay, so then you say, well, what about this information up here, right? That's what you're going to erase, right? That sensor fold up. There we go, save the, right. So now I'm going to erase what doesn't belong, okay? And we'll leave that one at the top of the incisal edge. That might be a contact, but that's a little bit outside, okay? And there's one that's definitely outside. Okay, so now I say save. Actually, I moved it down. No, it's okay. I moved it down, but I pulled it down a little too much. Let me just raise it up a little, just a shade. Just a hair, something like that. Okay, and then again, when you close this, it asks you if you want to save that, and we'll say yes. Okay, so now, these buttons, just to tell you, if I want to remove what I erased, that's what these buttons do, okay? When you save the movie and close it and open it again, the next time it will be without those tools. You won't see all those tools. This tool is the three-dimensional maneuvering tool, so that one comes up with any digital arch. The eraser tool will come up as long as this button is depressed, but these reverse, once you save the movie and close it, it doesn't come back with a chance to fix any more erasures. You can erase more, but you can't put back once it's saved. Okay, until I close it. If I did it now, it would put back what I erased. Okay, but what did I erase? I erased the stuff that was outside the incisal edge. Okay, so what does her data look like? And then we'll do the other recordings. So she has both recordings, she has a horizontal closure, so she's a little slow to close. The second bite, she struggled a little to hold her teeth together, but she did well. And we actually had a little bit more data, right? So there's a primary contact right there on the 1.7. That's not letting her close, right? And the center of force, instead of starting from the front, starts from the side or the posterior. Generally, it should start in the front. So this is the evolution of our pressure. So that's the timing. So this area is early to this area. That's why the center of force starts here.
That's exactly where she has the high sensitivity.
And she says it's her left side.
1.6.
So if we flip it, so it's, you know, because she's looking at us, she's looking at you guys, so we'll go like that.
Yeah.
Right?
That's it.
Right? So,
Now we push it.
right? And then she squeezes the full contact. So the right side is late to the left side. right? And the things that matter are,
Wow.
this matters very much. And this is what I said to you about red and, what does pink mean? Pink matters if it gets to you early in the movie. There it's coming in at 51% of total force. So what does that mean? It means the timeline is crossing the black line halfway into her bite. So if this pink showed up here, it wouldn't be anywhere near as much of a problem as it is showing up here, right? So some of the pinks, like watch what happens, right? This pink shows up at 70%. That's still probably a little too early. And those two show up at 80%. So these are better, if we would call them better, than this side, right? So this side is really holding her up, and she can squeeze that side together, and she can generate force on a few teeth. So if I was going to adjust this to improve it, I would be back in here. I would be treating this contact, the distal buccal aspect, or the most distal contact I could find on the 1/7, and then I would advance it. And I would treat that contact, which is one forward, so something near the marginal ridge of the 1/7.
Could be 1/6, 1/7.
And then I would treat these two, 2/5, 2/6. And that's pretty much, now watch what happens after that. Everything just gets worse, right? It doesn't, nothing new comes in, right? So you don't have to go any further than when you see that, this is called the key moment. The key moment is where you've played the movie enough to see what's wrong, and that's all you have to play. And that's a skill a user has to develop. That's understanding. Now, after this moment, if you look carefully, you'll see there's no new columns forming, right? Everything just goes up, right? So that's the data set. Then she's holding her teeth together, which things won't change. You also could maybe take a little off of this one, just because it's moderately high force. That would be the distal fossa. Now, if you look at the second bite, just to compare, you see a similar late rise, early rise to this, but now this side is a little bit earlier. Now, what's the difference? The difference is she struggled to do this, right? Here she didn't struggle as much. But the same progression is, this area and this area, not the same order, because the human being isn't a machine, but the same places, right? Then this gets worse, that gets worse. So this is the same two places on the left, just a little later, and you see the same basic here, 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 and here, right? That's what you would be treating. And then you would make a new movie. And that would fix that specific bite, and then you'd record it again, and you'd see what the columns went up again, until they all went up together, and you didn't have any more pinks and reds and yellows. But we're gonna lower the sensitivity and make an excursive recording. Everything.
Closing, basically, you're getting that
So-
first.
So
You're getting
between
all-
A and B is your determinant of what you're going to make the initial adjustment
In the closure,
in the closing.
yes. This is how you fix it, is you treat all these uneven force rises. So
In
that's
the A and B.
in here, 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 and here. That's how you'd fix it. And then you'd make a new movie, and then you would see what those columns do. And then when you get a good result, they all go up together. There's no more pink goes up here, yellow goes up here, red goes up there, green goes up here. They rise, there's all the blues, then there's some greens, then there's some light greens, right? That's how you get a good result for balancing someone's bite.
Yeah.
So she can't fit her teeth together because she's being held up in the back and in the middle of the right side. And you can feel the back on the left, or the left side doesn't feel so well.
So
Left side
her,
first.
her points are 1/6
Yeah.
and 4/6, and lower left side is 2/4 3/4 connection, and it's exactly coming up there.
Well, you can look at the lower arch too. We didn't scan it, but if you want to see the lower arch, just click on lower arch, right? And this is when you have the digital scan, it turns it gray. You don't have a digital scan, so you can uncheck that and you get the T-scan arch. And then here, what you would do, it's just to show you what we would do. We know that she doesn't have a 4/7. Do you have a 4/7? Let me see. Oh, we didn't take out teeth on the bottom, so we'd have to take out teeth. So, here what you would do is take out the premolars again.
That way, yeah. Missing close.
Missing closed. Missing
Allowed
closed.
extraction करते
Right. And then
3/8.
she has a 3/7, but it's not an occlusion.
That's right. yes.
Right. Okay.
By the time I finished 24 teeth, I got tired. The
Yeah.
last 4 teeth are not done.
Okay, so when we do that, this side sets up pretty well, right? There's data, into the near to the distal of 4-7. The 3-7 doesn't actually touch anything. It's out of occlusion. So we'd go like this, we'd go like this, and this we would move a little bit that way. Or we could use a central incisor width tool and stretch it a little. But this side was pretty good, so I just sort of guesstimated. And then you could measure these dimensions and plug them in here if you wanted to, right? Because we didn't measure the central incisor width. I'm just spacing it out visually, right? And then you see, click on this, and you see it in this plane, right? And this is her right side, and this is her left side, looking from the front. But you see the same process. Right? You see the same order. And this you can turn and rotate so you can see it better. Okay? Just drag it with the mouse. If you right mouse click, it'll reset it. Okay, we'll go back to the top.
How do you differentiate between making adjustments in the upper or lower?
Well, in this case, you have prosthetics on top and bottom, so it wouldn't matter. But if you had a single arch, again, like all composite against natural teeth on the bottom, you do the composite on the top. In other words, treating the patient, in this instance, because it's prosthetic dentistry, you'd want to balance the closure and remove all those fast risers, and then you would treat the excursions. Okay, but we're going to measure the excursions now. So she has an interesting situation. Go ahead, bite down again. She does touch the right canine pretty well. The left canine, she's a little bit low on the lingual, and she has a space. She has this orientation, right? So she's going to have a group function. Anyone who has this orientation always has a group function. Even people like this have a group function, but people who have this type of setup always have a group function because the mandible moves sideways before it can be verticalized. And nobody is really going to slide way out here, right? We're going to make her slide out there to record, but basically, he could go back in with composite, have her bite down, and fill this area in so it was flush. That would speed up her disclusion, even without adjusting, right? So right now she's set up to have some problems on the left side where there's no capability to disclude. So that's what I was showing you in those pictures, like, can this person disclude? Can that person disclude? And you saw some people can. They have canines that are flush. Other people can't. The ones that can't tend to have trouble adapting to their occlusion. Okay, so let's practice. Bite down for me. Okay. And she had plenty of time to rest because we were futzing around with the digital arch. It was on the wrong side, somebody said, right? Okay.
I was just testing.
Yeah, you're making sure I wasn't asleep. Okay. So I'm going to look at the screen again. Hit the button, bite down for me. Squeeze hard, good. Go to the right. Keep going, good, perfect. Okay, you can stop. That was really good. Yeah. So you see what happens with the digital arch? Each time, it may not come on as well as you'd like. So we'll do a quick, I'll just show you playing with it again so that we can show you what it involves using the mouse to rotate it. But if it comes on off in the future, we'll just, whoops, that wasn't good. I want to rotate it down. It's not letting me do that. Oh, that's interesting. I got to go the wrong way. There we go.
Are these software bugs that they need to sort out, do you think?
No, this is a process in evolution. This is one of the hardest things we've been trying to do for a long time. All right, so you can see this would slow you down chair side, right? So we can make the analysis without that. This orientation is going to take a little while to fix. Yeah.
So say if you want to take that off the thing.
You just click. Well, let me close this. I'll say I'll save the changes because I can come back to it. So let's say I wanted to had Manish send me some pictures of this patient to like lecture about how, like, this is a typical composite reconstruction. This is what, the patient had some trouble getting used to it. Before I would put it into my lecture, I'd fix this up so it was exact, and then I would be able to make slides of it. But chair side, if I was adjusting this, I don't have time to do this, right? So that's why you have to work with the T-scan arch. So to get rid of it, meaning to remove it, you just click on that and you get the, okay? Now the thing that really helped us is we moved the marginal ridge lines to match her
Yeah.
when we had the scan lined up, right? So this is pretty close to how she is. And the way you verify that is you look at the most forceful place, and then you look, how does the data fit? It almost fits. And this could be a real contact, but I would say it's probably more like that. And I could erase that if I wanted to. But that's all I had to do, right? So once you set the T-scan arch up correctly, you're going to get predictable data from that, right? So now we can look at this. Now this is an interesting thing. It says she's balanced, right? But she actually has one more tooth on the left side. So she actually should have more force on the left than on the right. This means she has very good balance. But balance by itself doesn't mean anything because the progression to get the balance is still heavily to the posterior left, right? Then the right side kind of offsets the left side in two places, right? So this is the same basic progression in the closure, okay? But she struggled to do it, right? That's because when she lands on this posterior left, it really stops her. And she has to force herself together, okay? And she does that by me saying, squeeze harder, and she did it. She did really good. Okay, so we're going to label this as a right lateral. And then we're going to have to figure out, okay, so it's the right lateral. First, the arch matches, right? We're going to drag the quadrant line down to between the 1,3 and the 1,5 because that's the canine premolar separation. And if you watch what happens in the graph near C, you'll see the colored lines will change. Okay, and that's very important, right? The quadrant line came on up here, right? That's not accurate for what we're looking at. We want to look at the anterior guidance, posterior disclusion separation. So now we have that separated. This is the right anterior quadrant, this right posterior quadrant. She began to move here, right? Here she's holding her teeth together. C belongs where these lines change direction. Horizontal lines mean the person isn't moving, right? They're stuck together, right? So if we play this from here, just to show you what I mean, nothing's going to change. She's holding her teeth together. That's the biting down part, right? So we don't want to waste time playing that. We want to, okay, this is where she makes her excursion. You click to there. Now you're ready to look at the excursion. Okay, so remember I said there's a skill to be able to read the graph without playing the movie. So I'm going to tell you what's going to happen in this excursion. She's going to move to the right. We know that. The posterior right quadrant is in control of the excursion in the early going. The posterior left is the orange quadrant. That's also involved. It starts to drop out, but then it comes back. So there's actually going to be a rise in force on the left posterior, and then it drops out and it comes back a little. The working side stays in contact, loses some force, but it stays in contact the entire way. And D belongs where both posterior quadrants reach 0%. So if you look at the orange line, it reaches 0% there. If you look at the blue line, it reaches 0% there. D goes to the right of the second quadrant that reaches 0. It's not the working side or the balancing side. It's the second quadrant that reaches 0. It could be either one of those quadrants, okay? So that gives us the disclusion time. Whoops, I didn't mean to do that. Reset. That gives us the disclusion time. The disclusion time is calculated by moving the lines correctly at 1.10 seconds. Just to show you what I mean, if I put the C line here, the number goes down, right? If I put the C line back here, the number goes up, right? You have to figure out where the C line belongs. The software got you close. You put it right in here. That's pretty close, right? It's probably just back a little bit. Something like 1 second would be about correct. Because she starts to move here. That's where the lines diverge, okay? Now, what happened in that excursion? What happened is the posterior right stays together. The center of force travels right into the second molar, right? Then it turns north, right? And goes back to the other side. Why does it turn north? It turns north because the right posterior quadrant starts to lose force while the left posterior quadrant gains force. Then they both start to lose force, and then the anterior guidance takes over. That's what goes on that you can't see with your eye, ever, right? 1 second, okay?
So So that orange one is showing up the non-working side interferences.
Yes.
Is that correct? Yeah?
Yes. The orange line is the left side, posterior. Everything under the quadrant line is, right, so if we come back here, right?
So when we do the DTR, we'll be looking at that very closely, right? Or
Working
or
side and balancing
Yeah,
side.
yeah, both.
Right, because her guidance is controlled by the working side.
Yeah.
See? And she has, on the right side, canines that contact. The left side, she doesn't have canines that contact. They contact, but they have that gap, right? Right? So that's going to be a more prolonged movement, I would think. But you see how there's group function, right? And a balancing contact. Then the anterior guidance takes over. That's what you can't see with your eye. If she slides to the right, it's going to look like she comes apart, right? Visually, but not at the micro occlusion. Doesn't happen, right? That was a very good recording, by the way.
So what you're saying is where the red line drops is where she loses contact on the 3,
Where the red line drops.
and the non-working interference, the orange line peaks. That's your interference
Right.
kicking in at the back.
Well, this is all interference. That's what you guys don't understand. You haven't been taught about working side group function. I'm going to have to show you the EMG stuff so you understand. Working side group function is all the problem. It's a much bigger problem than the balancing side, but no one's told you that. They've told you working side group function is good because it distributes force across many teeth, but it actually makes much more muscle activity and causes all the problems you have in symptoms, recession, abfraction, mobility, wear. All those things are caused by working side group function. And this is a good example of it because she's not going to slide all the way out to the right. She's going to chew to the right a small amount and chew to the left a small amount. And what you're seeing is 4 teeth are engaged around the central fossa when she moves to the right. Only 1 tooth is engaged on the left. So this 4 teeth makes much more muscle activity than this 1 tooth does. And that's where the problems come from, high levels of muscle activity. If we put the EMGs on her, we'd see that, but we're going to use it this afternoon with our patient. So not only is the balancing side a problem, the working side is more of a problem. And the red line is the anterior guidance. It doesn't work until all the way out here, 1 second later. That's when it works. Healthy disclusion is 0.4 of a second, where you have low muscle firing. And these are studied metrics. These are not, I'm not making it up. It's from studies, years and years of studying the disclusion time. So you see the group function is more powerful because it activates, more teeth are involved in firing the muscles. And that's typically what happens. Not all patients. Some patients, the balancing side is a problem. But most patients have working side group function before their anterior guidance takes over. That was a good recording. Okay.
It'll be great to see the left.
Now we'll do the left.
Yeah.
Okay. We'll keep the sensitivity the same. Okay. So let's practice again. Okay. Bite down and go left. Keep going. You just sort of slide out like. Yeah. And sometimes we have the patient slide in and slide out. It sort of teaches them. So go ahead, go left. Good. Perfect. Now come back in. Try it again. See, it's a struggle for her to do, right? She can do it.
Painful.
Does it hurt you or it just doesn't seem easy?
It's pain, like, you know, the upper teeth, this one, it's around here, I felt pain as well. You know,
Okay.
And then
In the molar and premolar region.
yeah, and this down.
Okay.
More it's the premolar. She has been telling me
Yeah.
3-5 and 2-5. There's only one premolar. Yeah.
Like
And now it's hurting you.
downstairs,
Is that your
the
face
office
being
is
sore or
pointing.
is that your...
She was premolar.
It's like, I don't know, I feel like, how do I say, it's a pressure and not like a high intense pain, but
Right.
it's a pain.
She has a bouncy feeling.
Bouncing.
Bouncy feeling.
Okay, well, what we want you to do is to make it hurt when you go left, okay? Because I want to capture it, right? Okay, so practice once more. Bite down and go across it. Slide out there. Yeah, keep going, keep going, keep good, perfect. Okay, now you see how a struggle that is, right? We're going to see that in the movie, okay? Lean forward just a little. The other
Forward.
Yeah, good, perfect. I'll stay behind you. Okay. Okay, so the same thing again. I'm going to turn around to exaggerate how I have to look at the screen. Okay, bite down for me. Squeeze hard. Good. Whoops, stay there. Go left. Good, perfect. That's a good one. So she let go a little, then she re-squeezed on her own. She knew to do that, so that was good. Okay, so we'll take the digital arch off. There's where she let go,
Yeah.
right? So we'll label the left lateral. We'll take the digital arch off, which we have to sort of click into this. Maybe move it a little. Oh, I wonder why it's,
Close that window.
let's see. We'll say yes. Yeah, there we go. Click it off. Okay. So, again, you can't set the C and D lines until you have the quadrant division correctly. And you can't have the quadrant division correctly until you make sure the data fits the patient. So the data just about fits the patient. Each one of these has just got a little data in the edentulous area. This isn't edentulous, but we know there's no counterpart. So I'm going to take the central incisor width tool, and I'm going to increase it a little until both have no data in the third molar or the edentulous area. Now I can drag the quadrant line down to between the 2,3 and the 2,5. And I'm going to, in this case, because there isn't any significant contact there, I'm going to try to pull it down between the 1,3 and the 1,4. This is a pain. Sometimes it's a pain. There we go. So something like that. Okay, so that changed the graph, right? Now, so she actually almost discludes. She gets close right here. The green is the anterior guidance quadrant. She gets close to discluding, but she doesn't because you see the blue quadrant persists, right? That's the balancing side. In her case, she's going left, but the posterior right is in the way. Early on, right, this is where she started to move, and these steps are friction, right? So early on, she has a group function. Later in the movement, she has a balancing problem. And she's actually generating a fair amount of pressure. She's able to close, and now she understands how to do it. Right? So she's going left. She has a group function. 2.5, 2.6, 2.3 is in play, 2.2 is in play. Left side, this is the right side. I'm sorry, I look at it the other way. So this is the left side is in play. The right second molar is in play. And then ultimately, she fights it out with the right second molar till she discludes, right? So when I'm watching her do this, I'm waiting to see this come up alone and everything else leave the screen. Then I turn the movie off, right? So that disclusion time is 1.11 seconds. So she's got, both movements are a little prolonged. And she actually, you know, I think in this movement, if she got some bonding done to take the canine and flush it against the lower canine, it would speed up the disclusion very much. It would help a great deal. And that's a simple addition to do, because this is a composite reconstruction. In the closure part, that's this side, right? Looks the same, right? It's a little better timed, but it's the same places, right? Each time. The 2.6 area, and then the posterior right. So this is important to understand. When you use the T-scan, you always defer to the worst parameter. So this parameter, the center of force, is saying there's good balance. It's hugging the middle. It says she's 51 to 48, right? This actually is a very interesting imbalance, 51 to 48. The side that has more teeth should have more force, right? Do you understand that? I've eliminated what's not equal, right? The 2.6 and the 1.6 are the last teeth that match up. So we could actually probably argue it would be something like that, 20% difference. Where is that 20%? 39 to 11. That's 26%, 27%. So there's probably one tooth that's a little more on this side. Yeah, 2 to 0, 2 to 1, right? That helps you know where you should be adjusting. A lot less pressure has to be on this tooth to get it to match this tooth. Now, it won't necessarily make it to 11%, but you can see this is the predominant area when we play the closure part of the movie. That's the predominant area, the 2.6. The piece we were looking at, this is the closure part, which I was just showing you, the nature of the imbalance. So this, all of this and this has to be reduced. And then in the excursive part, the group function, which you're going to see here, she's going to the left, which is this side. Show it like that. She's going to the left, right? That whole group has to be dissipated except for the 3, which isn't even involved, right? It's premolar guidance and molar guidance, and then a balancing contact. All of that has to be treated. And then she'd be able to move more freely. And the interesting thing about that is the lower premolar, first molar area where has pain, when she makes an excursion, is across those teeth, right?
You see, really.
Brilliant.
Right?
Brilliant, isn't it?
Brilliant.
So would you also work with that non-working interference on the other
Yes.
side?
Oh, yeah.
You would sort that out?
Yeah,
Fine, okay.
yeah. Now,
Amazing.
you can't get rid of them all.
Yeah, by composite. Yeah.
Right.
Everyone as well. Okay, ready, everyone? So, David, welcome to this course. You met Dr. Robert Kirstein.
Thanks, nice to meet you.
Now,
My pleasure.
colleagues, basically, David came to me referred by another dentist. He had some work done, a couple of crowns or whatever, and then problems were there. So the other dentist tried to make adjustments, couldn't really make progress in giving him symptomatic relief. And then David came and met me, and we did some initial T-scan analysis, but he's patiently waited up to this point to have the master treat him himself. So I think it would be lovely for us to understand how you've suffered in whatever the 6 months, 9 months, a year, what's been happening. Tell us.
Yeah, right, thank you. It was a good summary, actually, I think. I mean, I've always had, I've had a lot of dental work done over the last few years. I've cracked teeth and things like that with bruxism in the night I have. And so I've had a few fillings, and but most recently, probably in maybe July, August, September, 2020, I had about 3 crowns put in quick succession. After that, and I went back to the dentist who did it with the articulating paper to do that. And I always reported to him an unevenness, but he would ask me, how does it feel? And I'd be like, well, it feels okay. But then, of course, over time, a few days, few weeks later, I would, not feel comfortable with it. So anyway, a few months later, perhaps in September, quite late at night, I had a real tightening of my muscles. All that happened in a couple of seconds. They just all tightened, and I got ringing in my ears. And because it was quite late at night, I thought, well, I'm not going to do anything about it now. So I went to sleep, and I woke up and it was still there. And it's been there since then, really. So ringing in the ears, pain in the ears, muscle tightness in the face, tightness around the nose, like soreness in the joint itself, soreness around around the jaw muscles when I wake up in the morning. Yeah.
How has it affected your eating? Because you even told me you had to have altered eating pattern. Like, talk us in a day how you have to eat or whatever.
So I don't eat anything during the day now.
Because it would hurt you.
Yeah, well, it gets worse after I eat. So if I talk for a long period of time, or if I'm eating, I start to get pain in my jaw, pain in my muscles, headaches. Just the tightness, really. The tightness gets worse. Like the muscles just tighten up, and I get some pain from it, discomfort. And so painkillers don't generally tend to work. So I stopped eating probably about about a year ago, maybe. I stopped eating, less than a year actually. I stopped eating during the day, so I still eat in the evening, and I enjoy my food, and there's no issues there. But but during the day when I'm at work, I don't want to have to be distracted by this. So in the evening, I'm fine. If I start aching in the evening, it's no problem. I can just watch TV or whatever. So.
Also, you've seen a lot of different specialists, and just summarize to us, there's at least half a dozen people you've been or done all your rounds, and they've either said to you nothing's wrong or they can't help you. But just give us a summary of all that stuff.
Yeah, I mean, that's absolutely true. My GP, the first person I spoke to was my GP, and they put me on a course of antibiotics initially, and that took a few weeks to kind of go through that process and then try and get some referrals. And my GP initially didn't know really who to refer me to. So I've been looking on the internet, and we sort of concluded that it might be maxillofacial specialist that I needed to see. I'd also been talking to my dentist about bruxism as well. So I went through a number of doctors because of the waiting list for the maxillofacial specialist. As soon as I knew who I needed to see, I went privately and got a diagnosis. So a guy on Harley Street diagnosed me with having myofascial pain secondary to bruxism.
What was his treatment plan? What did he want to do to help you?
He didn't really give me a treatment plan.
Suffering pain.
That's not true. He put me on 10 milligrams of amitriptyline and prescribed me a course of physio, so myofascial, what are they called? Myofascial.
Physiotherapist.
Yeah, physiotherapist.
Yeah, okay, fine.
Specialist in that sort of TMJ physiotherapist.
Okay, yeah.
The TMJ physiotherapist I saw for about 6 months, and I had to stop in the end because I wasn't seeing any benefit from it. But I am still on the amitriptyline.
And you saw chiropractor as well, for some other specialists?
Chiropractors, yeah, for the the sort of neck massage. I mean, it's always nice. It's always nice to see like osteopaths and have massages and things like that. But it hasn't really made a material impact in the.
Fine. And then you did some research and you come across Robert Kirstein's work. So tell us about that then.
Yeah, well, that's quite interesting because I've been on the internet, obviously amateur googling stuff, and obviously found your videos on YouTube. Once I realised it was TMJ, then quick search and you're the number one hit, basically. Come up.
Well, to some degree, for bite problems, I would say. But thank you for that.
So yeah, obviously super excited that there might be a treatment that might work for me. Went to my dentist to see if it was available in the UK or if I could source it in the UK. Long story short, my dentist referred me to Dr. Ash, beyond my wildest dreams and expectations that I might have it done by someone such as yourself. So.
Did you have pain before those recent 3 crowns? So just turn the story back. Before those crowns were fitted, were you fairly comfortable, or you were?
Yeah. I mean, I'd had the bruxism and I'd cracked teeth, but I was oblivious to it in day-to-day life. Like, it didn't affect me. Dentists would tell me. Well, I've been told a few times over the years I have bruxism, but
And do you wear a mouth guard at the moment or not?
Yeah. So I've been prescribed a number of mouth guards.
Yeah.
I've had ones, £500-600 ones from laboratories and this kind of thing, and I bought off-the-shelf ones. I've not really got on with any of them. I have tried them. Like consistent wear. I've done it for about 3 to 6 months. Although the soft guards that I have, I tend to chew through them. Actually, you might say they make it worse because they encourage you to do it. I've had hard guards as well, and the kind of I forget what they call them now, but
when they move the jaw.
Move your jaw. I've used those for maybe a few weeks at a time.
Did it reduce your symptoms or not? Like, do you have one particular mouth guard that helps you?
The soft guards, absolutely not.
Okay,
The hard guard, it's difficult to say if it reduced it, because the weird thing is, and perhaps a good audience for this is, even if my teeth don't press together overnight, I still have the bruxism. Like, even if my teeth are quite separated with a hard guard, I still feel that my muscles are activated, even if my teeth aren't touching.
Yes.
Which is,
Also, when we did the initial teeth scan, there was 1 or 2 teeth where it was quite striking. We saw the peak of the force. Now, before we do your teeth scan movies, is there any way you can sense there's a higher pressure at the moment when you bite or clench?
This side here.
This side there. Okay,
Yeah.
so your left side. What? Go on.
Sorry, no, it's more of a question really, but appreciate that my bite has changed, and I do feel my bite change actually as the teeth, you know, erupt and so on and so forth.
Yeah.
And how does that affect things in terms of, like, the teeth scan will measure at a point in time my bite, but if my teeth are kind of moving, which I do feel them change, like not overnight, but certainly in
Yes.
weeks, and you know I do feel my teeth move around, and so how does that work?
Well, I can only speak from, you know, the realities of the fact that teeth are able to move, but they don't move dramatically. And it isn't to say that you won't see changes in people 6 months down the road or a year down the road. But someone did ask the question earlier about, you know, does it have to, I think it was you, do you have to, you know, touch it up every 5 years or something like that? And not really. You know, once it's straightened out to a higher level of precision and brings your muscle physiology down to a lower level, your teeth will be under less load, and then they'll tend to move less, right? So the muscle activity reduction stresses the teeth themselves a lot less, so they're not being shoved around the same. So the potential to move them goes down. It doesn't mean they won't possibly shift slightly, but, and over time, people do have subtle tune-ups, but out 6 months, 8 months, there's not a lot of benefit to that. You know, your bite change will be managed over a few months, and then it basically lowers your muscle activity, and how that heals you is what is the gray area of treatment, right? So we take the muscle activity away, and how much that helps the person is an individual healing curve. The interesting thing about his case is that he's told me today, he told you, the same story that I've heard from easily 1,000 people. I had something made in my mouth, my bite changed, now I have TMJ. The progression is the same, meaning the bite didn't, it isn't that the crowns were wrong, it's the change to his bite allowed the neurology to amp up, right? And now it can't be turned down unless we change the bite in a grand scale, right? We can try to grind the 2 crowns, it won't fix whatever shifted on the opposite side, if it were the crowns made on the left or on the right.
I think they're on either side.
They're on either side. So it isn't to say that you can't do a minor bite adjustment and improve somebody's condition, but it depends on the condition. Something like this, you won't succeed by doing only one side. And repetitively grinding the protagonist, the single crown, often isn't enough to fix the problem unless it's really a direct, I can't bite on that crown hurts when I bite down. Very much like what our patient before was saying, that she has some sore teeth over here. That can be relieved if that was her only issue. That could be relieved as a small scenario. But what he's talking about, the bite change, the muscle tension going up, the inability to turn it off, that appliances don't mute it enough, that's the reality of having high muscle firing, and an appliance can't override it. So the treatment has to involve both sides, even if the initial insult was on one side. And that's the only way to really bring the muscle activity levels down. And what he's saying is actually very, very, I would say appropriate's the wrong word. What he's saying is a very common story that afflicts the patient, obviously, dramatically, but it afflicts the dentist, right? The dentist did the work, now he's got a patient that's like uncomfortable. And the intention is never to do that. The intention is to make nice crowns and have the patient chew and function normally. But a subtle bite change can be just enough to get a few teeth rubbing together the wrong way for that person and set off this uptick in muscle activity that then goes from him not having symptoms, he was grinding his teeth, so he had elevated muscle activity, but it was below his threshold for discomfort. Now, if he eats, it raises his muscle activity above his threshold for comfort, so he's choosing not to eat as a solution. But the appliances can't mute the neurology. They're not, that's why they don't really work. They work for a period of time, but they won't work forever, and that's because the teeth keep doing the same thing when the person isn't wearing it. So his story is really, it would surprise me if we didn't see high muscle firing and it didn't lessen by what we did and it didn't help him have less of a problem. It would surprise me very much because it was a set off by his teeth, and now we're going to correct his teeth. And we're going to make it so his teeth make a lot less muscle activity. So my question for you is, if you bite down now if you put your teeth together and clench them, does it tighten up this area of the
Yeah.
bite? Okay, so
Yeah.
when we're done, he will be able to bite down and he'll have a lot less ability to actually make that happen, right? That's the power of fixing the neurology. He'll still put his teeth together, but it won't tighten that. And people say it every time it's done. They say, "Yeah, I can clench, but it doesn't like clench anymore. I don't understand." Like, it doesn't. I can put my teeth together and my face doesn't lock up, right? So that's the beginning of healing. So that's the goal for today, that you would be able to bite down and not see it do what it does.
Yeah.
Right?
Just to add on to that, I've been consciously not putting my teeth together for the last 12 months. Like, I don't do it. It's something I've just habitually, I don't do it now because it just causes problems.
Yeah.
What will it mean to you with exclusion time therapy and symptomatic relief to get back to your normal life having suffered this? What would that mean to you?
Yeah. I mean, if this works, I'd be super grateful. I mean, I might even cry, I mean, it's just the whole thing from the day it happened till today has just, it's knocked my life off its axis, I've not been able to really think about much, I've not really been able to, enjoy myself in social situations, really concentrate at work. I've not been able to do so much, and the only thing that's been on my mind the whole time is how to get this fixed. How do I get better? I think everyone's health is their number one priority, and I think you take it for granted until something happens that that maybe you suffer with your health, and then once you're suffering with your health, that's the only thing you want to get better. You can't think about anything else.
And the thing is, you've tried so many different clinicians, so today I'm going to sort it out for you.
Well, yeah.
Good, well done. Well
The
done.
thing about, just so you'll all understand, there is no way to tell someone this is going to fix your problem, which is giving you the absolute honest assessment. People ask me all the time, all these years, is it going to fix me? Am I going to get cured? I would say you have the parameters that should respond, but only by doing it can you know, right? So the patient has to be willing to be on board for it. And it's never something that I convince someone to do. I would, even to a degree, I would say I would not try to even influence them. I would say, you have the condition, your bite is making lots of muscle activity, your bite is set up nicely to treat, like David's is set up very nicely to treat, because I've seen it on Zoom, and that means he already has canine contact, so we don't have to create anterior guidance, but his anterior guidance isn't good enough for his back teeth, the way they're operating. But I wouldn't say to the patient, yeah, absolutely, it's going to fix you. You're going to get rid of all your headaches. I would say you have to go through it to find out, and that's the difficulty of it. So some people would walk away. They would say, I'm not going to have it done, but then I'd see them like 3, 4, 5 years later in my chair. They'd be like, I can't take it anymore. I got to have it done, right? And they went through many different attempts, like his road, but after seeing what the consultation illustrated, they chose not to do it. 5 years later, they chose to do it. 3 years later, they chose to do it. So when the bite doesn't get modified, the symptoms can't change. And they change only by increasing, not by self-resolving. The teeth don't self-fix. The muscle activity continues to be perpetuated, and the muscles, they just can't get relief because the bite keeps injuring them every time the teeth are put together, whether it's chewing, eating, swallowing. And so it builds on itself day to day, week to week, month to month. And the bruxing habit he had is not really necessarily a limitation, because a lot of people brux because their back teeth don't separate well. They don't brux because they have a central nervous system generated pathway, which has never been proven to be true. They brux because they're asleep at night and they've got stuff going on in their life, and their teeth come together, and instead of their back teeth separating as they move them, they engage and they trigger muscle firing. But that makes the mandible move, and then but the teeth don't separate, so they trigger more muscle firing, and the back and forth just keeps triggering the muscle firing, and they can't turn it off unless they consciously keep their teeth apart, or they try to use an appliance, which he said something very interesting also. He said he'd clench on the appliances. Appliances are not comfortable for people to wear, and they don't guarantee that you won't clench. And the bite surface of an appliance is not necessarily a highly precise entity. If it's installed with the T-scan, it has a chance to be highly precise entity. But if it's installed with carbon paper, the dentist is basically guessing at the carbon paper marks. He doesn't know what the marks mean. And you guys don't realize how that is such a poor outcome for anything we do, not just the night guard. You deliver a set of crowns, it could be a very poor outcome because there's carbon paper marks around the arch. Doesn't mean that it's balanced or simultaneous, right? And so the reality is you can put in an appliance that has a very bad bite surface and can stimulate a lot of clenching and grinding. And it in itself is a problem. So the beauty of DTR is he won't sleep with an appliance tonight, and he'll get to see how he feels in the morning. And there's usually at least an initial change of some noticeability that it isn't as sore in the morning, it isn't as tight in the morning, and that the person wasn't clenching as much. So that'll be a big plus for you. But other than that, I wouldn't predict how he's going to do. But at the same time, he sounds like many people that I've seen respond extremely well. So I think that's very encouraging. And the type of symptoms he's talking about, he gets sore eating. His face tightens up if he puts his teeth together. He's rubbing the side of his face, right? It's where the problem really lies, on the left side of his face. He may have a right-sided element to it too, but a patient who touches one side of their face, this is the problem zone, right? He can't get away from his teeth. He can try to keep his teeth apart, but he's going to chew, eat, and swallow, right? He's going to swallow, you swallow 1,000 times a day, so you put your teeth together no matter what you do. But you can consciously try not to eat, so he's gone to not eating during the day, and then when he chews at night, even though he gave himself that relief, he still gets the tightness, right? That's the teeth. They won't leave him alone until we make them so they can't hurt him anymore. And then he has a chance to heal. So the healing is like the stock market. The person has an improvement where the stocks drop, which is not an improvement in the stock market, but the symptoms come down because the teeth are no longer injuring the muscle. But the muscle has to still chew, eat, and swallow. The person doesn't get to put their arm in a sling. Like when you break your arm, you put your arm in a sling. You don't use it, right? Not with TMJ. The person has to chew, eat, and swallow and breathe. So they have to use their jaw, which slows the healing down. It's like walking on a broken leg. Is it really going to heal if I walk on my broken leg? But he can't not chew, eat, and swallow. He's got to live. He's got to survive. So the healing takes some fluctuations and kind of goes like this. Like you're at the top of the mountain and you come into a valley, you go up over the next mountain, you go down to the next valley, you go up over the next mountain, finally you get to, sea level, right? And that's over, 2 to 4 months with some repetitive refinements to his bite. But the only, the crucial piece is the first day. Without the first day, you can't start walking down the mountain because the teeth have to be altered to break the cycle. Okay.
Final question. Can you just explain to us about the analogy, when there's lactic acid buildup and the increased frictional contacts in the excursion? Because the DTR, just in lay terms, the concept of what we're trying to achieve today.
So when you have back teeth that touch in any way because of the neurology, and this is what we should really show you, and maybe I'll show you during lunch while you're eating, I'll show you what you're up against as dentist with every patient. It's not just someone like David. Every patient has the same neurologic tie-in. But when your teeth rub together in the back for too much time, they fire your muscles automatically. And friction, which is rubbing the surfaces together, goes on a lot in excursive movements. You just saw friction in the patient we had before, Nihu. She basically, can't get off her back teeth. She's got excessive closure forces, but she also moves laterally and her teeth rub together. That duration of time is equal to the time the muscles are active. And so when someone has friction in their bite, they rub their teeth together, it fires their muscles in this direction. They rub their teeth together the other way, it fires their muscles in that direction, and they can't stop it because it's a direct neural tie-in. And that's what I'll show you. So the prolonged friction makes it hard for the mandible to move freely while compressing the pulps and the PDLs and bending the teeth. And that causes the muscle activity to on-go. And then just like lifting weights, just like, if I do this with the barbell, 5, 6, 7 times, my arm is going to start to hurt. I'm building up lactic acid. The teeth are making lactic acid in all the muscles involved with swallowing. And once the lactic acid sets in, where it can't be metabolized out because the teeth keep pushing it in, by contracting the muscles automatically, the symptoms become chronic. And there's no way to break that cycle. Now, an appliance can break that cycle in the early going for some patients. Many patients I treated would bring in a bag of appliances and say, you know, this one worked, this one didn't work. They all stopped working at some point. I tried a new one. I bought one in the supermarket. You know, the same kind of thing. They don't change the neurology enough that when the patient doesn't have it in, this rubbing of the teeth creates all this muscle activity, and the lactic acid can't be metabolized. To a degree, if he keeps his teeth apart for 8 hours, he'd have some, you know, drawing out of the muscle activity. But as soon as he touches his teeth, it puts it back in. And then if he eats dinner, it puts it back in. And if he swallows, puts his teeth together, it puts it back in. So what the treatment does is it stops making the muscles contract to the same volume, a dramatically less volume actually, and that means there's a lot more time for the lactic acid to be metabolized. And then much of it gets taken away, but he still uses his teeth to chew, eat, and swallow, so some of it gets put back. That's why there's this kind of a thing that goes on. And so the time it takes to clear the toxic byproducts of muscle contraction are also fighting against the reintroduction of muscle contraction, even though it's a far less amount. And then that process just has to go on long enough for the person to get to a baseline where they no longer feel the impact of lactic acid. But the muscle pain you have when you do this is the same muscle pain he's feeling in his face. It's the same problem.
Does it take the same amount of time to build up the lactic acid in the muscle?
Per patient, it's hard to say.
Therefore, like you're basically, from what I'm visualizing, is that initially you've got that really quite a lot of friction.
Yeah.
And then the patient goes back and chews again, and you've got that lot of friction going on there. By relieving the interference there, you're getting less friction. How long does it take for that lactic acid to clear?
It starts right away, which is
It's
why the
immediate.
patients can tell that like they can't clench and create this.
Is it the same for muscles here as it is
Yes.
for the rest of the body? So that time is the same?
Yes. It's all skeletal muscle, right? So if I put, again, using this analogy, right, my arm is killing me now because I've been doing this for you guys, you know, every 10, you know, so I'm up to 12, 13 reps. My arm is killing me. I put it down, the lactic acid starts to leave right away, right? But if I pick up the weight 10 pounds less and keep going, I put the lactic acid back, right? And then I put the weight down. But if I pick up another weight too fast, I'll only be able to do a few more reps. That's actually a technique. It's called rest pause. You do 10 or 12 reps, you put the weight down, you wait 5 seconds, you pick up a weight, you do more until you can't do it, you put the weight down, wait a few seconds, right? That's a way to overstress your muscle, but you need that little break to be able to get some of the lactic acid out so you can have oxygenation. So what happens with lactic acid in any muscle is it competes for oxygen reception. And the pain you feel is your nerves saying, I need oxygen, and I'm not getting any oxygen. So when you put the weight down, oxygen comes in, lactic acid goes out. But when you recontract, lactic acid builds up because that's the byproduct of muscle contraction. Oxygen is displaced. That's where you get the pain. And the pain of exercise is the pain that he's doing. His teeth are exercising his jaw muscles more than he can tolerate, right? And he can't control it because of the configuration of how they rub together and fire him up, right? And
It's like asking you, like if you just run a marathon,
Yeah.
and ask you to do another marathon. And it's constant.
yeah.
Okay, well, I really appreciate everyone's input. So,
So can I
thanks.
just ask,
Yeah.
why does David feel that his muscles are twitching even though he's separating his teeth?
Ah, it's a good question. It's the nature of the state that he's reached. He's got too much lactic acid embedded, and he can't have normal function because he doesn't have oxygen. So he'll get a spasm, you know, even if and he could be getting some spasm because he's actively trying not to use his muscles, which is actually, he's not just letting them hang, right? He's trying not to let them touch. So he's maintaining some tone, right? In order to not suddenly find himself like looking at his computer screen and his teeth are together because his boss is yelling at him, right? So he's actively trying to not use them.
It's a conscious effort.
And that conscious effort is a strain in itself.
Yeah.
It's like, you know, if I want to hold my arm out like this, I'm consciously trying to do it. But at some point, my shoulder's going to hurt, right? I'm not going to be able to do it, right? And the same with your jaw. When you don't consciously do it, it hangs. You don't think about it. You're not doing anything, right? But if you have to try to maintain it in some way, you have to actively contract muscles to not make his teeth touch, because he's going to want to swallow. Physiologically, you swallow 1,000 times a day, and you don't think about it, right? So he's trying not to swallow. He's trying not to touch his teeth. That takes an effort, and so that would lead to some spasms in some people, right? And then the embedded lactic acid makes using the muscle very difficult. And you can do it, you can force yourself through it, like you can chew a meal, but it starts to kick it up, you know? And so it's an uncontrollable scenario of toxic byproducts, you know, competing for oxygen, and his ability to keep his teeth apart is also requiring muscle contraction. It's not just, I'm letting it hang. Right?
Okay, if you, yeah, no, right. We'll have a break now from just the filming. So thank you all. We'll ask more questions. Obviously, we're going to do the treatments. So have some lunch now, everyone. And
so his temporalis contracts right there. And I put that right over where my finger was. You don't have to clench anymore. Good. And you can just clench it only. You don't have to overdo it. The lead of the master is. Oh, but meaning you can go back and forth. Bite down for me, dude. Squeeze hard. Good. And open. Squeeze hard.
Yes, correct.
Good. Open. Go ahead and bite down. Squeeze hard and open. And bite down again. Squeeze hard and open. Good. Okay, so we have 3 pinks. So that's pretty much ideal starting sensitivity. So we'll give him a rest for a second. We'll look at his data. You can keep your teeth apart, David. So this is the muscle data. It's time-stamped to the T-scan data. So you see A1 is here, A1 is here, B1, C1, D1. This is the lead time. This is all the stuff we talked about earlier. That's resting EMG. So he has actually very healthy resting EMG. He doesn't have really any hyperactivity. He clenches pretty well. He opens. And this is again between the 2 bites, which is the same as between here and here. He bites. He's got good contractile strength. So his data set, he's got a pretty good data set. You see his right posterior, actually we flipped it. So it's his left posterior rises faster to pressure than the right side does. Okay, so that's his back right. I'm used to looking at it backwards, so you have to forgive me. That's his posterior left teeth. And this is why you want to record in turbo. Just to point out, we were talking about turbo. Turbo separates the sides and the columns much better than non-turbo. So you can see the left side is early to the right side. Okay? And if you remember, I said symptoms don't have a lot to do with balance, right? He's got decent balance. His arch sets up pretty well. I'm just going to drag this line down a little. The other side matches very nicely. There's very little to do about his arch. We measured his central incisor width, and that gave us a pretty good distribution. So I'll save that one. And both clenches look pretty good. He's, a little slow to close. The second one, he's same shape, but a little bit faster, a little bit better. But you see the same progression, right? There's the left side before the right side. Okay. All right. So let's practice. Go ahead. Open. So he got a little tired there. He didn't get it fully the same kind of strength. But he did still generate 3 pinks. Okay, so he actually came apart pretty well. Although looks like he went to the left. That's so interesting. Let's see. Let's see what happens here. So I asked him to go to the right. I'm just going to show you this to you guys. You see the green line rose. So it's possible he went to the left, but it's also possible that the posterior left controlled the excursion. We'll find out in a second. The data matches. He went to the right. Did you go towards me? Yeah, okay. Where's right lateral? Right lateral is there. The arch matches, so I can move the quadrant line up. Yeah, it looks like he went to the left, actually. quadrant line would go there. Yeah, it looks like he made a left excursion. See, he went, that's the left excursion. There's some group function. There's some muscle activity up in there. He closed slowly, so I had to make him squeeze. I'm going to call this a left lateral rather than a right lateral. I think he went the other way, just by the data. You'd never see it look like this. You would never see this take control if he went to the right. Okay, so there's the group function, but he comes apart pretty well, at least going to the left. Now let's try going to the right. Right,
Which way?
to the
Right, towards Robert.
Yeah,
That's
but
it.
keep these teeth together. You got to slide over those teeth.
Is he going too fast across? Do you want him to go slower?
It's his speed.
Okay,
He
that's
can
it.
go slower, but more important that slide right. You
Just
keep
do it
those teeth
normally.
together.
Yeah.
Okay, that's the key. Not to open and move.
Yeah, keep
Just
together.
slide
That's
right,
it.
exactly.
Beautiful.
Okay?
Very good.
And again, I'll tell you when. Squeeze hard, squeeze hard, squeeze hard. Good. Go to the right across your teeth. And that looked like you went the right way. Okay, yes, so that was better, right? So it says the red quadrant took over, okay? So the data fits the arch, a little short on this side. That kind of a flat line might be that the sensor was a little bit off center and we didn't get the last little bit of data. So that's possible. Doesn't mean we can't look at the data. It was
Right lateral.
right lateral this time, which is, why can't I find it? I have two right laterals, there we go. And I would say we can keep the arch pretty much the way it is. I mean, I might move that up a little and maybe move this a little, but not dramatically. And then this goes between, actually I have to check the left lateral, between the 1-3 and the 1-4. Okay, so then over here, that's what I said when I watched him, he came apart pretty well. So he has the group function. His anterior guidance works pretty well. He doesn't really have much of a balancing contact. And then here's the when he goes past the canine. So if we look at that, so he's going that way. You see he has premolar guidance, lingual of the first molar, buccal of the second molar, lingual of the second molar. Balancing side, he's got some premolar guidance, balancing premolar. In other words, he's dragging across the premolar. And while he's doing that, if you look up here, I'll let you drag it down, make it bigger. You see the muscle firing. It tapers the closer he gets to D. The interesting, the non-working temporalis, which is the left temporalis, it shouldn't fire at all, and it's firing. And his right masseter fires. His left masseter fires when he goes to the right, because his is resting EMG. And you see this spasm and an increase in muscle activity. Okay. And then we'll do one more to the left, just to make sure.
And then we'll be check his disclusion times as well.
Yeah, well, I can just, the value of the disclusion time really is important, except for, like, even if it's short, like it's pretty short here, I would guess it's probably 0.6 of a second maybe, let's see. You see there's muscle firing going on in that period, that's because his back teeth in play. So even if we shorten the time, we still, even if the time is fairly short, 0.7, right, we really want it to be, maybe in his case, 0.3,
Yeah,
right?
yeah.
So we're going to try to speed it up. I hit the sensor twice. And there also might be a break in the sensor, which is back here. See this? He didn't bite. I hit the button 2 times, and so he didn't really get a chance to bite. And there's data on the screen. So that might mean the sensor is from rough tooth, there could be a break there. So let me throw this one out. No. And let's see if we pull up a new movie. Yeah, so you see that this area is clean. That's the posterior. In this case, we have it as, that's the left, right? Posterior left is back here. Okay. I'm just flattening the sensor a little, because it could be a rough tooth. It could be a sharp surface there. Okay. And we don't want any perforation. So practice again. Bite down. You go left across your teeth. Good, just like that. Perfect. Okay. I'll try not to hit the button twice, which does happen. And again, I'll tell you when to do everything. Bite down for me, squeeze hard. Good, go left. Let's see what it looks like. Yeah, he squeezed hard there, that was good.
That was good.
Yeah, he went left, it's a good movie. So he let go, he squeezed hard. Here he went to the left. Okay, now, let's label it.
Left.
Left lateral, which is here.
Do you want to delete the first left lateral or keep it?
I've had
Keep
it
it,
for years. So his arch is pretty close again by measuring it and setting up. This is a little over in the third molar, so I'm just going to pull that down. I don't really need to change the other side, and it's not a dramatic change. And then the quadrant line goes between the 2-3 and the 2-4, which is important. And then you can see there's some group function. He actually comes apart very well, which is interesting. You see the group function is right there. It's not dramatic, but the D line belongs actually out here. Even though you see some blue, this is in crossover. So he made it to his anterior guidance, which is there, and then he passed the canine. I'm going to guesstimate around there. Let's see what happens when he goes to the left. Yeah, so he maintains contact on both sides, but he really comes apart very well. So it's more like, what is the muscle physiology of that? And you see there's a spasm in the left temporalis, that's the working temporalis. But the other muscles aren't really affected too much by him going left. The right movement is worse for him. Yeah, let's see if we can make that better. That's actually, he moved pretty fast. Try to do it a little slower. I just want to see that one again. I don't want to tire him out, but just let me watch you do it. Bite down and slide left. Like, yeah. No. Now go left. Okay, good.
Sounded good.
Yeah. That's a more appropriate pace. A lot of the patients want to, yeah. See, that's what I mean about how it has to be done naturally. So you see this huge spasm now that, you know, by going fast, which he would never do on his own, he wouldn't chew fast. He would just chew naturally. So you see this huge spasm in the left temporalis in the middle of the movement, right? That's the kind of thing that would cause symptoms. So what teeth are causing that? Well, the beauty of these systems is you can just click into the spasm and it shows you all the teeth that are creating that spasm, which is posterior group function, balancing second molar, balancing premolar. So let me save this.
Yeah, left lateral.
Left lateral, right. Oops. Okay, and the data fits very nicely, right? We don't have to do anything to the arch. Put this between the 2-3 and the 2-4. I'm also going to re-record the right at that same speed. Okay, so this is what's important. So we slowed him down, and you see the same thing. Okay, the group function is there, which actually, you know, is. Let me put this back up.
Orange.
Let's back up.
So the orange scale.
See, the orange quadrant rises, and look where the spasm is. Right where the group function is at its peak. Right, see the orange line is at its peak. So we got to slow him down a little so we can get more natural data. So the group function is predominant. There is a balancing component, that's the blue, right? But he does reach his anterior guidance well, which makes him relatively simple to treat, meaning he discludes on his own, but he still has muscle activity. I'm going to call it like right out here. You guys can look carefully. You see the blue and the orange are getting to 0. The other feature of that is the green fails to reach 100% and stay there until there. And then he passes the canine and falls over it. So C to D at a natural pace would be somewhere out here. I'd say probably right at the base of that little V. And that would give us a more reliable time of, well, it wasn't that much different, 0.6 of a second. Muscle physiology is responding to the group function, okay? But he has great anterior guidance capability. You know, I can show you some cases later, when we go back upstairs, where you see incredibly different long, very long disclusion times and what that means to someone. The other feature that's important is the center of force. It goes to the side when there's group function. So it goes right into the middle of his arch, right? And then it turns north when his anterior guidance takes over. So if we can get this to go more like that, that would be better. And the goal is to eliminate this as much as we can. Bite down, squeeze hard, go to the right. Good. That's a good pace.
Yeah, see more data.
He really comes apart nicely, which is good.
Sorry for the, yeah.
Oh, did he go to the left again?
That was right. No, that was right.
I wasn't sure on that one.
You went that way.
Well, the green quadrant rises. So one way to know is usually the non-working temporalis turns off. So let's see what happened here. It looks like from the center of force he went to the left.
Should we do it again then?
Yeah, well, let me just give him a
Finish.
chance to rest and we can analyze it. But again, this is the area of concern. The area of concern is to the right of line C. And of course we have to make sure it's all set up correctly. The arch matches. This line has to go up.
West.
Yeah, he went to the left. Yeah.
Okay.
He might have gone left and forward a little because you see the same group function. And then you see there's some red. That usually means you traveled a little more forward. He might have been confused. So we'll just, you know, we'll label this one as, it's certainly not a right lateral because the green would never rise. So we'll call it a left lateral, but I'll make a note about it. So one of the software features you have is a notepad, which you can write in patient left anterior. And the note is kept with the movie in the database. So what I mean by that is, if you notice I've saved all the movies. If you open the patient file, this is the note I just made. Patient went left anterior. So you can write a lot of things. You can write a Bible if you want to. You know, patient has jaw pain, patient has headaches. Okay, try again. Coming towards me. Lie down, slide this way. Good.
Nice.
All right.
I'll watch him actually, see what he does.
Okay. Yeah, because I can't see under the
I'll watch
sensor.
now, I'll watch.
Squeeze hard, go to the right.
That's it? No, definitely right.
Okay, good. Yes, we ended up on the
No,
right.
definitely right.
Yeah. Oh yeah, I keep pulling this away so I can see it. Okay. Yeah, he went to the right. You see the red line rises.
Mm-hmm.
And this part of the movie is crossover. He passed the canine and he fell down on his teeth. Okay, so the data matches. The scan type is
Right.
right lateral. Whoops.
No.
Yeah, well sometimes with the gloves on you get
That's
these.
it.
Right lateral. So you see with the settings to label the quadrants, right?
Comes up.
It comes up automatically. And then in between the 1-3 and the 1-4, this has to go. There we go. Almost. Okay. So in both movements, he actually has very good separation. See, his anterior guidance takes over, I'm sorry, with the gloves. His anterior guidance takes over very well. And that's good. And he started moving here, where the horizontal lines change direction. Oh, sorry about that. And this is where he started moving. He's able to bite, he's able to hold. He has good strength. So even though he has tension and tightness, it's not really making him dysfunctional. It's uncomfortable, but it's not dysfunctional. So he's right there. And you see to the right of line C, I'll blow this up. This is muscle activity that occurs right around the central fossa. All of this to the right of line C. And he has spasm in the non-working temporalis. Now you look at this, the thing to understand about this trace is that there should be nothing here. It should be flat like this, When you move right, your left temporalis shuts off. So even though it doesn't look like a lot, that's actually a lot. It should be flat. There should be nothing. So whenever you see data in the non-working temporalis, you have a patient that's hyperactive. Then in the working temporalis, he has spasms as he moves. And notice, in the graph, he has group function, that's the blue quadrant, that persists. And once he gets to the D line, this volume tends to go down through here, but not when he goes over the canine. So here he passes the canine and he runs into his back teeth. He's never going to function out here, but it just shows you how powerful the mechanism is. As soon as he gets back teeth on the screen, the muscle activity starts to go up. So if I drag this across from there, and he maintains that contact, right, that raises muscle activity. And the left master is definitely bothered by going to the right. And it's been bothered by us making him use it. So this is resting EMG, and then it worsens during the excursive movement, meaning this is worse than the resting EMG. Here you can see it's kind of spotty spasms. Those are vertical lines. Here it's denser, taller, fatter band of muscle activity. Okay. All right, so we have all we need.
If you save that one, Robert,
Yeah, I gotta save it. But the good thing about this, the good thing about his case, as from a treatment standpoint, he has good lift.
Do you want to do a protrusive one?
Yeah, we can do a protrusive one because he has a tipped up second molar. Just make sure. So he has a tooth in the back. I think it's the back right. That's a
This time with a bike.
little bit problematic. Let me just see his time.
Okay. Just a natural pace.
Yeah, so this is an example. I didn't mean to open it and close it. This is an example where, see, the time is good, half a second, but the early part of the movement is not good for him physiologically. That's right around the central fossa. So he discludes well, but the group function component, the blue, aggravates this much muscle activity. It raises muscle activity in these four muscles. Right, and if we look at his group function components, let me drag this back. Watch the center of force move towards his back teeth. It actually goes posterior. See, it turns down like a drag. My mouse is frozen. Here we go. And then it turns north. So we really want to try to, in the treatment, to get rid of this piece of it. We want it to go that way. Sometimes we can, sometimes we can't, right? So again, using the EMG, what teeth are making that muscle activity go up is the group function. Okay. And then we'll do a protrusion. So you're going to bite down. Not sure if we can. We keep the sensitivity the same. Bite down. Squeeze hard. Good. Go forward. Good. So he goes a little bit further forward. He goes past each guiding surface, which is okay. And he's getting good at clenching. He actually gave us one extra pink. Yeah. So protrusion doesn't make any muscle activity. So protrusion isn't really an issue for him. And you can see that here. As soon as he moves forward, everything turns off. So that would be relatively simple. We wouldn't even have to treat that, to be honest with you. We wouldn't even look at protrusion. And most of the studies all of the studies that we've done actually show that we don't treat any protrusion in the research. Because most people naturally will protrude and disengage very well. So same principle, move the line up between the 1-3, the 1-4, and the 2-3 and the 2-4 this time. So I'm going to try to find the best place for all of those. And when you look at the graph, you can see, I'll move the D line out of the way for a moment. You can see the red and the green anterior quadrants are in control. That's meaning he's using his two centrals, one on each side of the midline, or he's using a central on one side and a lateral on the other side. But you see how the blue and the orange just come apart, right? They go to 0. So he has some canine control. He has a little bit of early contact there, right? You see the premolar on the right side, left side, I'm sorry. I have to remember it's reversed for you guys. And you see now I'm at the red and the green taking control, And that's one central on each side of the midline, which is pretty ideal. And then he shares it with the lateral. Right? And later on, he picks up a little bit of rubbing of the premolar, but it's negligible. And that's this orange. Right? So I would have to say he probably passed his incisal edges there. And then he got some back teeth in play. Yeah. Okay. So if I was to pick D in this movie, it would probably be right about here. You see there's no back teeth in the screen anywhere. And that's a very short disclusion time also. Okay. And you see this part. No muscle activity, no spasms, right? Okay. I just want to make a note of it. Yeah, 0.3 of a second. So he really discludes very well. So that's going to make him easier to treat than someone who can't disclude at all.
See all the areas of the crown?
That looks like the carbide. Is that a carbide? Or is that the...
No,
No?
that's the red one.
What's different about it?
I mean, they come together more easily. They're flat. It feels like it's flatter.
Yes.
And like, you know, before I talked about the sort of wonky paving slab analogy,
Yeah.
it doesn't, it feels like it comes together a bit, you know, more evenly now. So I don't do it too often, but I should.
No, well, you'll get to do it plenty after we record if you want. Although I will tell you this, these are instructions we give the patient. So the biting down, or the clenching, if you would call it that, is actually, even after treatment, it still makes a lot of muscle activity. So you didn't get to see any of the data, but this is, if you look over here, this is, see, you make a lot of muscle activity. We're going to make new ones now after you've had a few more minutes, so that's why I don't want you to bite. But this piece of the recording, which you're holding your teeth together, that's when people like go like that. And when you do that after this procedure to test your bite, as opposed to when you're naturally like eating and chewing and swallowing, but people will leave the office and they're like, is it good? Is it good? You know, like going like that. They're amping up their muscles by saying, you know, how does it feel? How does it feel? How does it feel? So you really don't want to do that, even though the tendency is to try to test it, right? Now we want you to test it so you can give us some feedback, but in terms of after you leave, you know, today, just let it be and use it, but don't focus on it because it's new and it's challenging for some people to get used to the newness. And it's hard to test it out, and all they're doing is firing their muscles because in the base bite, which is what you have now, you still make muscle activity, and we're going to see what the sliding looks like. And then we might have to touch up some of the base bite. So now we're going to look at A to B and C to D. So C to D, we're going to, his C to Ds are pretty short. But if we got rid of that spasm in the temporalis,
Make it shorter.
we made it shorter, right? Which is an improvement in the muscle physiology. Even if it went from 0.6 to 0.4, that could be an improvement that's marked for someone. It doesn't sound like much, but depending on the person.
But it feels like it comes together more easily, definitely.
Good.
And it's more. There is still a bit on this tooth. Feels like.
That's your canine.
Yeah, the canine feels like it makes contact first.
So you're now hitting your anterior teeth better, and some of that is that it's changed, that you're actually closing a little differently. Some of that is you may not have actually been striking it as well, and now you are, and the nerve isn't used to it. And some of it could be actually be pressure. So when we record, you will see.
Right.
And if it's normal pressure, we would just maybe dust it a little. But if it's extreme pressure, we'd have to take it off. You know. And a lot of times, what happens is as you relax your muscles, you come forward and you can bang into that kind of thing. But it's good for us to not adjust it. When we do a live course, it's good for us to just record it and see if it matches up to what the patient says. You know, because they're watching upstairs or whatever, and we know he feels that's the left one only.
On the left side,
Yeah,
definitely.
so when you go in and touch these things up, so the guidance line is there, the base of the guidance line closest to the gum line is the closure stop. All right, so David has told us that his teeth fit together better, although he feels some pressure in the left first premolar area. So we're going to record that, obviously, and we're going to see if it correlates to the bite pressures correlate to his feel, or if it's a timing issue, like it's a first or early contact, and we're also going to record the excursions, and we're going to look at the end result now that we did by eye, and we're going to optimize it. So we're going to actually fix it up using the data. And some of it is his field, but we're actually going to fix it up based on what we find with the T-scan. So we're using the same sensor and the same sensitivity. That's very important. Whenever you adjust anything, if we were delivering crown and bridge work, 14 units of crown and bridge, we'd use the same sensor and the same sensitivity all through the process. Because you can only grade the changes if you use the same things. And the EMG leads are on his head. We haven't taken them off. We left them where they were so that we are getting the same muscle locations being recorded. So we're trying very hard not to change that environment. So let's say you had to go to the bathroom in the middle of the procedure and you've got to unhook them from everything. We would disconnect these things from the box and we would send them out to the bathroom. See, these come out of the box. We'd send him out to the bathroom with these wires hanging from his face, but we wouldn't take these off at all through the entire process. Okay. And we've been having him keep his teeth apart so he could get some reduction in the lactic acid. Okay, so now and instead of making a multi-bite, I'm going to make a bite, hold, and slide to the right because I can get the A to B part in the excursive movie. I can get the closure part to look at and the excursive part. And that way I can save him from making extra recordings. We don't want him to have to do a lot now. He just had the procedure. We want it to be a minimum post-operative correction. And this is actually what comprises visit 2, 3, 4, what we're going to do now. It's you optimize at the end of visit 1, you optimize the visible correction, the one we did by eye, and we're going to now fix it with the T-scan data. And then when he comes back, the things that we do now, recording right, left, fixing up a little, that's what the rest of the treatment is about, while he accommodates to the new excursive function. Okay, so you're going to bite, hold, and go to the right. So let's practice. Bite, and slide right. And keep the corners. Go ahead, bite down, squeeze hard, go to the right. Good. Okay, so we have a little hyperactivity in this muscle, right? And he made a very good recording, so very little blue or orange remaining at all, okay? So this is actually what we want. Now to find the disclusion time, we need to be where the D line needs to be where the blue line reaches 0, which is really right there. And where he starts moving is pretty much where the non-working temporalis turns off. And it actually turns off pretty well. There's still a little early spasm there, but we'll compare it to the pre-op right laterals, the last few that we did where we got really good data. So this is actually a pretty good result. Let's see, the DT is 0.46, so I think it was like 7/10 or 6/10, something like that. But we'll come back and look at that, and we'll compare to the beginning. Now the closure balance, right, is pretty low force. This is the right canine premolar area. He's feeling it over here on the left. That's going to be this contact. Let's see if it gets worse. Yeah, it doesn't really get worse. So we take a little off of that. Oops, sorry about that. With the mouse with gloves doesn't really work. Okay, so let me turn it like that. Yeah, you can see it better. You can actually see the column rises better when you flatten the playback. You can see what I mean by that. There's a little bit of early force on the centrals, but not too bad. The right canine area, the left canine area, they're both very similar, and then this contact shoots up. So even though he doesn't feel this, we could actually treat some of this over here. And what he feels is over here on the 2-4. And that's actually a low force contact. So it shows you that people can feel stuff that is not high force. And it isn't that early either. It's just the way the tooth gets loaded. So what you would fix, Ash, in this recording is the mesial and distal of the 1-3, the 2-4 mesial, and the 2-7 palatal cusp. And you just go in and tap, 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 and that's what you, so that's our next correction. So now you go in and do that.
In CO.
Right now, in CO. Right? And we only choose those contacts. We don't.
So no excursive.
No, we'll look at the excursive in a minute, but you can see from this graphing that the red, the orange, and the blue just disappear. They don't hang around.
Nice improvement.
Right? And that's what we want. See, that's when he's letting go, and now he starts to move, and you see the center of force take a big change. So the center of force initially moving is him letting go, and then when he actually moves is when it goes like that. And so that's a good outcome. If we just click to here and watch what happens, basically everything dissipates. Nothing really hangs around. In the back is what I mean, in the back. Okay, so now you'd make a left lateral, so I'll make a left lateral. And we can sit you up a little bit again. Go ahead and bite down, squeeze hard, go left. What's interesting with that movie, I think he slid in off his teeth, so I may not accept that. We'll have to see. It looks like he did okay. So he bit down and he kind of let go. The reason I said I thought he slid in from the front is you see some high impact that then goes away. But that's actually because he let go, right? So this is the closure piece. So we actually did pretty well. We almost moderated it. 1-2 mesial or 1-3 distal in 2 places on the second molar, first molar, the 1-6 central fossa, the 2-6 central fossa. That would be the only correction. So we got rid of the 1-7, we lessened the palatal, the premolar. The canine area we did pretty well, but we still have a little bit of this. You see that right there? And so we'll touch that up too. Yeah, we got 2 places to adjust. Let me just save it. The data matches. Notice how everything is much lower force. We didn't actually work on the closure at all. Now, if you remember the left lateral, there was a big bump in the orange, right? Now, the C line is definitely in the wrong place. C line should be right there. So what happened in this movie is he bit down and he began to let go before he made the excursion. Now, this is a minimal let go, not to say it's good, but it's reality. He's tired, right? He made the excursion from 80% of total force. He didn't make it from 100% of total force. And this is a common thing you can see. Now, why does the C line belong where it does? He's holding his teeth together, and there's where the lines all change direction, right? That's where he began to move. And we can check that against the non-working temporalis. Look at the non-working temporalis. He's clenching here, and the non-working temporalis shuts off. And there's the spasm that was huge at the beginning. Now it's just a minor spike. And the disclusion time is actually very good. I would say it's probably a little bit more, the D is probably a little bit more over right there. Would be, let me see, yeah. So look what happens. The orange drops and he catches a central incisor, that's the red rising. So when the orange and the blue drop, it's right there. So the C to D is actually very short. And compare this spasm, look at that spasm. Let me save it. To the last left lateral we made before treatment. So these are the movies we made before treatment. So let me just make sure I'm not missing anything. That's the left lateral, right lateral, right lateral, right here it is. All right, look at the spasm and the group function.
Let me get closer.
Okay. This is the pre-op left lateral. So here's the group function. Here's the spasm. Now look at it after treatment. There's almost no group function, and there's almost no spasm. But there is a spasm, right? It's just not as violent, right? And that's because the group function doesn't go up in force. But as I said, there's no zero disclusion time, and the center of force goes towards the anterior teeth, right? So we've achieved a lot in terms of like improving the muscle physiology, improving the disclusion. Now we just have to finish the balance. So in the balance, you take a little away from this area and these 2 places, and that would end visit 1. Okay?
Okay, could you just make the 3D, just tilt this a little bit for me?
Tilt it down.
That's it, yeah.
Okay. Well, this is the map you use to locate.
Okay, yeah, is that better?
Because this is the location on the teeth is easier to define. So it's either the 1-2 distal or the 1-3 mesial. So it's 1-2 distal.
I can see clearly here on the 2 distal.
Okay, so there it is. It's on the 1-2 distal. That shows you how important it is to set up the dental arch. Right, there it is. You see it's between the buckle. So notice you can adjust that one. It's between the cusp tips, but notice how far to the buckle that is. So you see there's a mesial mark that's closer to the marginal ridge. Notice that's not his buckle, right?
Yeah.
So It correlates exactly.
This one here. That one?
Exactly. And does the, when you bite down, you do notice the premolar as much anymore?
Definitely.
Better or not?
Yeah, better, 100%.
Anywhere else that's a problem right now?
You can have some water too. It's good to just spray some in there because it helps you to, you know, when it's really dry and grainy, it's hard to know.
No, there's nothing obvious now.
Okay, good.
Comes together very well on all sides. I can't notice any nerve pain or anything or any discomfort.
So we do one more teeth and
Yeah.
oh no, that's
No,
it.
that's
So
it.
shall I just polish the three
Yeah.
areas I did?
Just polish those areas, but before you do, so why don't you film David so we can just ask him for the group.
So David, we've just done the DTR treatment with Robert Kersey and myself.
Visit 1.
Visit 1, this is visit 1, longish visit. Tell us your overall feedback.
Yeah, procedure was good. My muscles are definitely more relaxed in my face. My teeth come together better than they did before.
Yes.
It feels more even. I'm still trying to get used to it.
Yeah.
Does it tighten up your face as much when you bite down? You can see your muscles are contracting, but does it feel like it's sore to bite down, like it triggers your muscles?
No, it feels much more relaxed now, definitely. It feels like my muscles are not having to work as hard.
So if you had been biting down before, you would have had tension build in your face, right? And you were avoiding that.
Yeah.
So you would get a response.
Yeah.
So now when you do this bite down, we can see your muscles contract. So go ahead and bite down for everybody. You can see the masseters pop out a little. All right, go ahead, do it again. All right, you can see it pops out. But it doesn't feel to you like it tightens things up like it did before. So that's what I'm asking you.
Yeah, I'm just trying to get used to it, I guess. But it's definitely relaxed. My bite is definitely better. It doesn't feel awkward now to close my mouth, whereas it did before. Like it was uncomfortable for me to put my teeth together before. And it's not uncomfortable now. Yeah, they come together. I'm just trying to get used to it, really.
Good.
But yeah, the muscles in my face are more relaxed. They're not as tight, no. Yeah, it feels a lot easier.
And if there are true clenchers and grinders, meaning you hear everybody's a central nervous system clencher and grinder, I would say it's only 10 to 20% of the people, in my experience, that are actually central nervous system bruxers, and they'll come back at 7 days and they'll say, you know, I was bruxing some, but it's nothing like it was before, and I knew I was doing it because I woke up and my teeth were together, but it didn't set off my headache or it didn't make my jaw ache. Those people we might use some kind of an appliance with after 30, 40 days after they've had a chance to accommodate. But most people actually come back and they find that they aren't really clenching and grinding as much and they don't need to wear something. So and a very important instruction is don't wear your splint. Let yourself sleep for the first time without it, and not to play with your bite. And then then this is also a very important instruction, during this week, this is actually information and instruction. So I'll say something like, your muscles are now, as you can tell, they're not as strained and they're beginning to relax, which means your mandible is going to move a little. And it's nothing you see in the mirror. You don't look different, but where you close becomes different. And he'll hit some places that we didn't adjust, because where he's closing now or before will be slightly behind where he's going to be. Generally, most people come forward. As the muscle lengthens, the mandible falls forward. So they bang into their front teeth. So you might find that the feeling you had on the premolar that we took away, you might feel it somewhere else. And that usually takes 3 to 5 days to occur. And in order for the muscle recovery to begin actually overtaking some of the lactic acid buildup. So you'll find your bite will be maybe a little bit different, and you'll notice it, just like you notice the premolar. You don't have to go looking for it. It'll just be there, right? And that's why your person has to come back in 7 days, is to touch up some of those things they feel and to redo what we just did on the second half of the visit. Bite down, slide left, fix it, both the closure and the excursive part, although both excursive parts Ash did really well. I mean, you look at this graph, which I think is this one, and you see how the yellow line goes up and then drops. And so there's a big change in terms of the time of disclusion and the physiology. Look at that spasm that occurred right around the peak of the group function, right? Now, there's no spasm. It's almost gone, almost gone. And sometimes when that happens, when they hit too hard somewhere noticeably, that amps up their symptoms. That's why the curve of symptom recovery is a drop, an uptick, a drop, an uptick, a drop, and so that's what you'll experience. And then out 60, 90 days, it doesn't really happen anymore. You know, you're just sort of accommodating the new place. And those are the instructions. So,
Okay, thank you.
yeah.
Good, so we done with?
Yeah, we can just polish and those guys can take a break. We'll take the Band-Aids off his face.
Okay.
The survival skills you need are breathing, digestion, swallowing, blood circulation. Those are all your survival skills. So you don't sit around and say, you know, I'm not going to breathe now. You know, I'll breathe in a few minutes. You know, you just breathe, right? Your brain makes you breathe. Your brain pumps your blood around your body. Your brain makes you go to the bathroom. You can fight that one, right? You can say, oh, I don't really want to go to the bathroom now. But 10 minutes later, your brain is making you go to the bathroom, right? It's not easy to prolong that. And that's because you have to clear these toxins out of your body, right? So swallowing is a survival skill. You have to swallow 1,000 times a day, and you have to close off your airway properly, which is in order to swallow food and not have it go down into your lungs. So what happens is when you're chewing for a while and all of a sudden you swallow. Your teeth, as they get closer together in the bolus, your brain says, oh, the teeth are rubbing together, we're going to swallow now. And then but in the beginning of the chewing, the teeth aren't together, the bolus is too big, right? And you're just sort of moving the food around in your mouth, and then as the bolus gets smaller, your teeth mill together, and it makes these muscles contract. And then you put a new piece of food in, and you do the same thing over and over again. So the swallow mechanism is a fascinating group of muscles. So this is from a neurotext. This guy writes a new edition every year or so. This was the 8th edition in 2000, but you can find edition 12, edition 15. I don't know if it ever changes, but the first time I heard about this reflex arc was in prosthodontics school. The periodontists were lecturing, and they said the PDL fibers go directly into the brain. And no one really picked up on that, meaning no one's really explored that, what it means to dentistry, other than like tactile sensitivity. Like, for example, you may have been taught that reflex arc is why if you bite into a rock, you don't keep biting, and you don't crush your teeth, and you don't crush your alveolus, right? You bite into a rock, a moment later your teeth are apart. But tolerated compressions, where your teeth rub together and they're not maximal compressions, they don't make your jaw fly apart. That's why a clencher or a grinder keeps clenching and grinding. It's tolerated compressions of the PDL, right? So you just keep going, right? So here's the pathway. This is 5th and 7th cranial nerve afferents. The blue ones are, I think, 5th or 7th, and the red ones are 5th. And notice in this schematic, you see at the periphery, there's all these synapses, right? Except for the green pathway. The green pathway is from the posterior teeth, and it travels directly into the mesencephalic nucleus, which is part of the trigeminal system, and the fibers travel on from there. They don't synapse in the mesencephalic nucleus, they synapse in the trigeminal motor nucleus. And this is why when you saw in the EMG, the patient bites down and they clench, all that muscle activity comes up because you're compressing these PDLs, and the molars are making the muscles contract just by the compressions. And that's the clenching. That's why the clenching causes a lot of symptoms, right? But there's a fascinating part of this that no one really talks about either. The fibers they synapse bilaterally, but they also go into the center of your brain. This is called the reticular formation. So this is a diffuse area in the center of your brain, which is like a massive brain center. It's not clear where it starts and ends, like the pons. They know where the pond starts and ends, but they don't know where the reticular formation starts and ends. So it talks to both sides of your brain and all kinds of structures, and it controls breathing, circulation, digestion, sexual function, and posture. Okay, so it controls 5 major things. And the swallow mechanism is part of the digestion system, right? So that's why this, I believe, has also this sort of evolutionary neuroanatomy took place. But it's also the reason why if you have a toothache, you can't get away from your toothache. It's talking to the center of your brain, right? You have an abscess on your lower molar, you're in trouble. It's not going to, your brain is tapped into it directly. So this is why we see things like a person will have their bite adjusted with the T-scan, they'll get disclusion time reduction done, and their posture will suddenly stabilize. And we see that with a lot of people. We actually published a paper, 92 patients who had, over a 5-year period, who had posture metrics done. They weren't coming in for posture treatment. They were coming in for TMJ symptoms. They used posture metrics, where you're standing on a posture plate, posture graphs, like you have the person stand up against a wall and behind them is pictures, and then you have them turn to the side, and you can measure like how far forward is their head posture, what kind of sway do they have when they close their eyes, you know, can they stand straight, are their shoulders even, are they not even. And even in the first visit, like he sat up and said he felt better, right? Well, we also can do posture metrics right after treatment. And it's interesting, you look at the patients and, you know, their rear end is sticking out a little and their head is, you know, forward, and then after DTR, their rear end is still a little bit out, but their head is no longer so forward. 3 months later, they're like this, right? So this is the teeth pushing back into the center of the brain, right? Pushing all this electrical activity into the center of the brain. We can't measure that. We can measure it on the face, right? So that's one of the amazing things. That's why we see a lot of strange things that people come back and say. But one of the most important things they say is they sleep better. And we found in CT that disclusion time reduction opens the airway without moving the mandible, no appliance. The airway widens. And in those books, there's a chapter which looks at just a case report, but the original airway was 41 square millimeters of available airway space. After DTR, 207 square millimeters of airway space. So it's not just a little bit of airway opening, 5 times bigger from relaxing the upper airway musculature, which is part of the swallow mechanism. So the swallow mechanism is, these are the structures that the teeth talk to. The muscles of mastication, the tensor tympani. Now he had ear symptoms, right? He had ringing in the ears. We'll have to see about that one. That one I've seen in my life, 50% of the time it gets better, 50% of the time it doesn't get better. So meaning it either went down, like it doesn't really happen anymore, or it does still happen and it doesn't change at all. So the tensor tympani is the muscle that controls the tympanic membrane. And that's why when you swallow in an airplane, you clear your ears, right? You open that or contract that, one or the other. The tensor veli palatini, that's the muscle that closes off the palate, closes off the airway from the esophagus, right? That's your soft palate. So when you're swallowing, you don't get food down your throat, down your lungs. And the mylohyoid and the digastric, which is submandibular area. And we just had a person we treated a few weeks ago, I think it was in Houston, yeah. When I was in Houston, we treated a girl who's a singer, an opera singer. And she said, you know, my throat is always tight when I sing, and it's affecting my ability to sing. And I've treated about 5 singers in my life, and they all came back and said they were able to sing louder, taller, you know, longer, easier, right? And they would specifically go to this tightness through here. Well, that's the submandibular area, right? And the palate, soft palate in the throat. So the reach of the teeth is always these muscles. But if you look at what's being innervated, this is why the symptoms are always the same. This is why people get headaches in this part of their head. This is the masticatory musculature. This is why the face bothers them. This is why their ears bother them. This is why, you know, their eyes, this region bothers them. And then this area bothers them. Not everybody gets all of that, right? But they always get the same types of things, and they tell you that if you take their history. They're touching this part of their face, they're touching this part of their face. So what did he touch? He touched over here, and here, and here, right? So, and V3 also talks to V1 and V2. So you can get mid-face pain from your teeth pushing back, and it comes out on another branch of the trigeminal nerve. So it's a really powerful mechanism. So TMD itself is really when the swallow mechanism backfires on the patient. It makes too much muscle activity, and the person gets tired and sore, and they get pain, and it's just because their teeth are rubbing together. It's not because they grind their teeth. It's not because they have a crossbite. It's not because they have, you know, these habits that it's just day-to-day use, working up their muscles. And the other little known fact, so this is the cycle of vicious cycle of vicious symptom evolution, or the vicious cycle of symptom evolution. Typically what happens is a person will start to get symptoms when they're in their 20s. It's not always true. There are plenty of teenagers and post-orthodontic teenagers I've treated, but typically it's 20 to 25. So they'll say something like, the symptoms came on, I was in college taking exams, my face started to hurt, I was grinding my teeth because I wasn't getting any sleep, and I started taking Advil, and then my exams ended and my parents took me to Florida and the symptoms went away. Then a few years later, it didn't matter that I took Advil, pain medication wasn't working, I started to get headaches more, so I went to the dentist, I've been grinding my teeth, they gave me a night guard. The night guard helped me, right? I was getting better. Right? Now they're 27. The night guard isn't working anymore. I'm taking much more Advil. I'm grinding my teeth more. I got a new night guard because I thought my night guard was wearing out, but the new one doesn't work. Right? Now I'm 35. I have migraines. I can't sleep as well. I'm grinding my teeth much more. My face hurts all the time. I can't chew. So what's happening is the lactic acid is building up with every chewing stroke, every swallow, and it begins to outweigh the recuperative capability of the person. And it takes years for that to happen. And it can be accelerated by like a punch in the jaw or an auto accident where their head gets jarred, right? Those kinds of things. But typically the evolution is a slow progression. And it's because of this mechanism. The teeth rub together thousands of times a day. The molar pulps and PDLs and the premolar ones also go directly into the brain. They automatically contract the muscles because it's a one-switch system. There's no muting that system. Whoops, sorry, I'll put it back so you can see. There's no muting this system, and then ultimately the cycle repeats with every chewing stroke, with every swallow. You can't turn it off. It's going on without your control. System is mediated by the breed and feed system, rather than the fight and flight system. But the little known fact is that the trigeminal nerve is used by 3 cranial nerves to get to places on the head so they can innervate their end structures. So in other words, the oculomotor nerve uses some aspect of the trigeminal V1 branch. I'm not sure what you can actually find out what the branches are. I should find out what the branches are. But it hops on and then it hops off, kind of like getting on the subway at station A and getting off at station B. But that means the teeth are pushing back to that cranial nerve. Well, there's 3 cranial nerves that use the trigeminal nerve to get to their spots on the head. The oculomotor nerve, the facial nerve, and the glossopharyngeal nerve. So the teeth are talking to 4 cranial nerves in the center of the brain. And all this pushback affects the human who's susceptible to it. Like, Ash may have bad disclusion, but maybe it doesn't bother him. Maybe his body can manage that electricity. But people who can't manage that electricity are getting symptoms around their eyes. They're getting symptoms in the midface. They're getting symptoms in their throat. They're having trouble standing up straight. They don't know they're having trouble standing up straight, but they're having trouble standing up straight. They don't digest food as well, or they go to the bathroom more often than they should. There's all kinds of potential things that these cranial nerves in the center of the brain are emitting with this electricity affecting them. And then once it's relieved, it isn't that they become brand new people, but the stories are hard to turn away from. There's a woman in California, a dentist I trained in DTR. She's posted a lot of videos on YouTube. She's got people who have talked about brain fog going away, like people who don't feel like they're clear-headed. They don't have TMJ. They just don't seem to like feel right. And then they got their bite adjusted, and now they're like, wow, I have clarity. Not like that day, but maybe 2 months down the road, 3 months down the road, they notice, geez, I don't have that anymore, right? And the only thing they had done was have their bite adjusted. Someone else, I had plenty of vertigo patients that were on meds for vertigo. They didn't get treated for vertigo. In other words, I didn't say I'm going to do this, it's going to fix your vertigo. They had TMJ symptoms, but they had vertigo as a component of it. And then their TMJ symptoms went way down, and they stopped having to take antivert, which is a medication for vertigo, and within a few weeks, right? So the power of this, the teeth, is really not understood by our profession. And the neurology is at the core of it. And so it's important that you understand when someone says TMJ and occlusion have nothing to do with each other, they're completely wrong, completely wrong. They're moving in, they're promoting an agenda that's completely unfounded in science. And there's not only the neurology, but there's also all kinds of research that's been done that shows that fixing the occlusion, and I'm talking about research that we've done that's in those books, that is occlusal adjustments, just like Ash did today. That's the main treatment that has fixed all kinds of things. And yet again, it's not 100% foolproof. Someone can have it done and come back and not feel like it made a difference. So that's a risk that any patient takes. I can go in for cancer therapy, right? They can take out half my spleen, but if they don't get 100% of it, two months later I've got cancer again, you know, and I'm going to die. And nobody sues the surgeon, right? But you grind a little enamel away and the person gets a headache and it doesn't go away, they're ready to sue you because, the next dentist they see says, no, the bite adjustment doesn't work, right? And what they're talking about is equilibrating, what we were talking about earlier. When you equilibrate, as we said, you distalize the mandible and you take the front teeth out of contact, that worsens the disclusion. That's why there are no equilibration studies that actually have metrics that show you can treat people. But there are about 80 disclusion time reduction studies that show you can treat all kinds of things. So that's the neurology. That's what you're up against every day. It's working in your office whether you want to see it or not. My partner says something like the forces of occlusion are at work in your practice whether you treat them or not. Right? Right? And the only way to treat them is with measurement. You can't treat it with carbon paper. Every time I did the CRCO part, people said their bite felt better, but no one ever really dramatically responded, which is not to say that it isn't helpful. It helps to make the teeth fit together better. It's not really good positionally, but that wasn't really anything I was questioning at that time. But whenever I did the excursive part, which you're supposed to also do the anterior guidance after you do the CRCO, the people said that they noticed it felt a lot better. So we used to I shouldn't tell the whole story. So we used to illegally work in the dental school at night as residents. We'd bring in patients. We called it drilling for dollars. We're spending a fortune to become residents. So at night we would bring in people to do fillings on and crowns on. So one night I had this girl who needed her bite adjusted. She was a headache patient. And right at the time I finished, right when I started, I said, I'm not going to do the CRCO. I'm just going to do the excursions, and then I'll see what happens. And we used T-Scan 1, and I did the same kinds of recordings that you saw today because I was figuring out how to record this stuff. So right when I finished the part that we did today, the first part, the phone rang. Well, back in 1985, 1986, you didn't have a phone. You had to go to the phone. What I mean the phone rang was someone came in from the prosto lab and said, I had a call. So I had to leave the patient. So I left the patient. Right at the time we finished, it was almost like the same minute. And I came back, 7, 8, 10 minutes later. She goes, I don't know what you did, but my whole face is relaxed. And then I knew I was on to something. Wow. So I started studying it. And I didn't have EMG. So I ended up doing the first study that I didn't show you any real research, but the first study was done with separate EMG. People went to a clinic that could measure EMG. They made excursions. We measured their EMG. And then I treated them. And then they went back. And they had the EMG done a second time. And the muscle activity levels were different. It was a different way to look at it, but the same idea. And I actually show the real data sometimes. And then the T-Scan EMG wasn't built until 2004, so I actually did a lot of treatment without EMG, and for many years, because I didn't have it. But once we had it, we realized that we could use the EMG to really make a difference for the person, and yet it was treatment with the T-Scan. You absolutely need the T-Scan to be able to quantify these things. But subtle things in the EMG became very important to find. And that's what you saw today, because there was a problem there that we could actually see. And when you don't have the EMG, you won't know. Let's say you did a good job. You made the DT from 1.5 seconds to 0.6. With the EMG, you can find out that you really needed to be 0.3 or 0.2. You won't know that without the EMG. So that's the challenge of working without the EMG. But there's no question you can shorten the disclusion time with the T-Scan, and that involves getting your T-Scan skills up and getting,
exactly.
Right?
So what we should do, I think, is the first 3 basic things you said. Take very good records, analyze them better yourself, then go and fix it. So we can start fixing things. Yes. You could, if there was someone with long distance, if there's certain obvious things, then you're going to do some equilibration, even if you didn't come on this course, right? You've got enough skills to do some equilibration or some knowledge from your prosthodontic training or occlusion teachers you've had.
Yes.
So they said tomorrow I'm lecturing for the first time, you're lecturing. I'm talking about traditional occlusion, the way I've been taught all my life, and he'll come in and talk about his stuff, and it'll be interesting for the audience to compare and contrast and what it's all about, right? It's not to say that one doesn't work, because I've got clinical results over 20-25 years which are successful in inverted commas. You learn, we all have failures,
but there is no measurement for it.
But there's no measurement.
Yeah.
But there's no measurement, and if there's a problem, but if there's no problem, you really do not know how to fix it properly.
Which is difficult with variables.
Which is difficult. Whereas with this, you can predict the problems, you can treat the problems, you just avoid problems.
You're backed up, right?
You avoid problems.
She could have been delivered, right? She could have been delivered with the T-scan. Theoretically, you would have found all those things and fixed it, and she'd have a lot less of these weeks of that, right? And that translates into all of you. In other words, that's a problem.
Because the thing is, you made a beautiful smile, but at the end of the day, you've got to be comfortable as well.
Right. Well, I would say get your T-scan skills up, upgrade if you don't have T-scan 9 or 10. Get the right software, learn how to use turbo recording. The things I told you today are they're all very critical, and they mean a lot, and they make a huge difference. So once you get good at that, you may treat some people, you may shorten their disclusion time, no question, and it'll help them, no question, it'll help them. But it's not as predictable without the EMG. With the EMG, it's not as predictable.
Would you say there was value, like let's say, for obviously we have the equilibration side of things. If we have someone that's not got TMD problems, we come in and we're doing like a couple of crowns both sides of the mouth, taking a baseline record and then just checking for marked elevation in that, just to say, well, it's probably going to be all right then.
100%.
With that.
Yes.
Yeah. So up your.
Thank you. Yes, so, yes, there's a lot of value in that. And most of what you'll do in your life as a dentist involves putting in things and making sure the bite management is appropriate. So, if you're making 2 crowns, I showed a nice case about it yesterday, my own mouth with some implants, how I preserved my own contacts around the implant, so I didn't change my bite, even though, but I still got my 2 implants in, and I got them low force, and I adjusted them. My partner, my friend adjusted them. But the point being, when you drill stuff away, you lose stuff that might really matter. So you really want to have a baseline that you try to preserve, right? And then you won't have these problems. He said exactly what I saw many, many times in my life. How many times people came in who said, I had this done, my bite changed, and now it's years later, and I'm suffering. And we don't know who that's going to be. And of course, we want them to crown their teeth or fill their teeth. We don't want them to walk around with decay and leaky restorations and, bad, unhealthy teeth, right? So you do these procedures, but in the process of that, you can make a problem change just by drilling off one contact. Sometimes only one contact is what changes, and that's enough to shift the bite, get a few teeth into each other that weren't striking so well. Now they're striking better, and that kicks up the neurology. And it magnifies with everything else, like when you do 10 teeth or you do 4 teeth versus 1 tooth, right? The potential for it to destabilize is very high. So I think you would only benefit from having measurement to help you do a better job.
I feel like I've had such a blasé attitude for putting things into people's mouths now. I feel like I've been so reckless. Like, I'm just like, they seem comfortable, that's nice, I can't see anything obvious, but this is like really...
Well, no, but isn't that true? Isn't that
misunderstanding of things?
But isn't that true for most of dentistry? Not as a criticism, as a reality. Most things we put in, people accept. And I wouldn't say the word tolerate is the right word. I would say accept, that they're not neurologically challenged by what we do, right? But the problem is we don't know who's going to be neurologically challenged. And then right? That's where it's a can of worms that you can't know. And there isn't any way to know because you have the T-scan either, that they're going to be, you can get a really horrific looking T-scan result, not a treatment result, but let's say you make a big scan and you see these terrible things, huge imbalances, bad disclusion, the person should be, having all kinds of problems, and you look in their mouth and their teeth look like they're beautiful enamel, no recession, no gum pocketing, nothing's wrong.
Those cases, just leave it.
You just leave it. Because the T-scan will always show you what's wrong. But you only want to intercede when what's wrong is creating breakdown,
Correct.
right?
Correct.
And
Symptoms
you
of
know,
breakdown.
Broke, not fixed.
yeah, I mean, because just so you understand that, and then we should let you guys go home or go to dinner, but the T-scan measures relative force. So you can always find relative force imbalances in your mouth. It's
Yeah.
not measuring pounds per square inch. It actually is doing that underneath the surface, but it's not anything you can translate to. Like, it doesn't matter if Ash bites with 500 newtons and I bite with 350 newtons. You got to fix his bite so it works well, right? If you knew that it was 500 newtons, it wouldn't change what you would do. You'd still de-stress the teeth that are taking 300 of those newtons rather than leave 300 on 3 teeth and reduce, leave the, not treat the ones that have 10 newtons on them, right? You don't need to know the numbers. You need to know where there's too much and too little, where the timing is bad, where the excursions are bad, right? So that means when you use it, it's always going to show you stuff. But the beauty of that is if you see an area, there's a huge concentration of high force, you can look in the person's mouth and say, Mrs. Smith, your gums are receding, and I got this technology, it's showing me why your gums are receding. Look how much pressure is on that one tooth. If we leave it there, you're going to keep losing gum and bone support. Stuff we talked about yesterday, right? These are the same examples we talked about yesterday, right? So,
Yeah, just use it for normal dentistry.
yeah, so.
Guys, thank you very much. Right, big round of applause for Mr. Robert.